Morning, everyone. Okay. Thank you again for coming on a Sunday morning. Just some, it's easy like a Sunday morning, yep. So, few things before we start. Again, please make sure that you have the QR code for the registration and for the evaluation. Also, Janet, okay, that's fine. That's fine, yeah. And then give your name to Jeanette if you didn't do so, just as a backup in case something happens with the QR code. We don't get the evaluation. We'll make sure that you attended and you get your appropriate CME. Okay. So this morning we have good presentation, good talk. We're going to change a little bit the schedule. We're going to start with Dr. Lisa Lemond. She's a heart failure specialist at Mayo Clinic. Thank you very much for coming, Dr. Lemond, and supporting us. We had her in a conference a few months ago, and it was an amazing talk, so we're very excited to have you with us again. Our moderators will be Dr. Nabil Deeb, the head of our clinical research, and Dr. Deval Shah, the head of our cardiovascular department. Without further ado, we're going to start with Dr. Lemond. One thing toward the end for the physicians, there will going to be a certification with LivaNova for the Tandem Life. So if you guys stay toward the end, you'll have a course and you'll get signed off on the Tandem Life. Thank you, Dr. Lemond, again, and we appreciate you coming today.
Thank you. All right. Great. So hi, everybody. Nice to meet you. I'm Lisa Lemond. I am an advanced heart failure and transplant cardiologist at Mayo Clinic in Arizona. I am primarily based out of the Phoenix campus. Don't do any time over at the Scottsdale campus, and I have been here for 7 years. I came here out of fellowship training, and I did my training at the University of Colorado and in Portland, Oregon at OHSU. I love what I do, and so I'm really grateful to be able to be here to speak with you. I actually struggled a little bit when I was putting this talk together because I thought, first of all, I mean, it's an entire talk about something that I spent an entire career doing. So it was kind of hard to condense it down into what I thought your group would want to know. But I did my best, and if there are any questions at the end, I'm happy to answer questions, and hopefully we'll have some time for that. If there are any additional topics that you want to learn about, I'd be happy to do more. So I just want to thank you guys again for the invitation to come and be here. So I don't have any pertinent disclosures. The objectives for today's talk are that we're going to define advanced heart failure, talk about some of the pre-heart failure team management, and then I thought I would talk about innovations in heart transplant and LVAD, and a little bit about our outcomes and how to overcome barriers. So what is end-stage heart failure? So end-stage heart failure is any terminal process by which medical therapies are no longer effective at reducing symptom burden or prolonging life in the setting of heart failure. And this setting can occur both as an inpatient or as an outpatient. This is kind of my definition. There are other definitions for what end-stage or advanced heart failure is, but this is kind of how I like to think about it. And for our heart failure patients, whether it's an acute process or whether it is a long-term process, this is really the end of the road for them. So they're either showing up to you in extremis in the hospital, or they're people that are really struggling to get by in their daily life that are showing up to you as an outpatient. And this is a shock symposium, so I chose today to talk more about the inpatient and acute shock management of these patients. The outpatient management is a little bit different, but as you all know, cardiogenic shock can occur from a number of processes, but really any process that affects the heart and becomes a terminal process, whether it's a pump failure problem, whether it's a rheumatologic problem, whether it's an electrical problem, they can all eventually end to or result in cardiogenic shock, and that's why we're here today to learn more. And I'm sure in your other talks, we've talked a lot about cardiogenic shock, the identification of it, the classification. And so up at the top, we have ambulatory shock. So this is somebody that is walking around, or excuse me, acute MI. Somebody walking around, they have a sudden event or a myocardial infarction. They get sick, they go to the hospital, and they show up to you very sick. Below that, we have our chronic ambulatory shock patients. So these are people that are the walking wounded, people that are sick, going about their daily life, their heart failure is progressing, and all of a sudden they find themselves very sick, sicker and sicker. They might show up to you in your clinic, or they might show up to you eventually in the hospital, and then require further treatment. And so for our clinical classifications, we have people that are pre-shock, so people that are working their way towards developing shock. We have people that are frankly in cardiogenic shock, and then we have people that are in refractory cardiogenic shock. Our ACC-AHA staging, all of these people are going to be in stage C. Some of these people are going to be in stage D. Sometimes we joke that there's a stage E heart failure, so people that are sicker than stage D. Sometimes we see those patients in clinic. They're all going to have really significant symptomatology. So they will at the minimum be class 3 symptomatology. Class 3B symptomatology are people that are an outpatient, but they have symptoms with really very minimal activity. So these are people that come to you and say, I can barely walk across my house without getting short of breath. And then there are patients that have ambulatory class 4 symptoms, so symptoms at rest. And then there are advanced class 4 symptoms. Those are going to be people that need to be in the hospital. Intermax profiles are what we use to describe patients that are going into LVAD, and so we usually reserve LVAD therapy for people that are Intermax profile 4 and above, although there have been some trials that have looked at doing LVADs on patients earlier than that. They haven't been super strong in terms of their outcomes, so we really reserve LVAD therapy for people that have rest symptoms. And then for our SKY stages of shock, we have stage A, people that are at risk for developing shock, B, the beginnings of shock, stage C, which is classic shock that we all take care of on a pretty regular basis, and then D, those patients that are deteriorating, and then E, patients that are in extremis. And so really important to think about the people that are in shock and what stage of shock they're in, because it does impart a significant mortality difference in how we take care of them. And again, classically, we take care of people that are in stage C or D shock, and then at our center, we tend to take care of people that are at stage E. And so really important to define what kind of cardiogenic shock we have, because it has important implications. So is this somebody that has what type of profile? Are they right-sided dominant, left-sided dominant? Are they biventricular shock patients? And how do we do that? So we do that with invasive hemodynamics, and then the rest of the clinical picture, put it all together, and it tells us what type of shock the patient has. So I really like this table because it goes through the different types of shock, the hemodynamic profiles, and I'm sure that you're all very familiar with this, but people that are pre-shock are people that have good blood pressure, so systolic arterial pressure greater than 90. They can have variable CVPs, variable wedges. The CVP to wedge ratio can be different depending on the primary driver of their heart failure. Is it right-sided? Is it left-side? And their cardiac index is usually above 2.2, and their SVR is usually on the high side. So pre-shock hypotensive patients tend to have blood pressures of less than 90 millimeters of mercury systolic. And again, variable profiles depending on the ventricle that is the primary driver in the clinical picture. For LV dominant shock, you're going to have a high wedge and a low CVP. And so those are patients that might have had an acute myocardial infarction on the left side that are showing up to you with kind of the classic shock. And I think this is the picture that most of us think of the most when we take care of our shock patients. Typically, they have a cardiac index of less than 2.2. Sorry, is this backwards? Yeah, less than 2.2. It looks backwards because I'm looking at it kind of from behind. Anyways, so RV dominant shock, these are patients that are really challenging to take care of. The reason that these patients are so challenging to take care of is because they don't often look like our typical patients that we see. They tend to have a lot of congestion in their belly and in their legs. Also, I will say that in my experience, RV dominant shock, when it's showing up subacutely, tends to be in the normotensive range. So these people tend to have kind of less hypotension when they're showing up in your clinic. But these are people that are going to come into you, they're going to say, my belly just feels so full. They're going to have a pulsatile liver edge. They're going to have a lot of peripheral edema. They might have scrotal edema. And when you look at their hemodynamic profile, they're going to have a high CVP compared to their wedge. So often in these patients, we have a CVP that exceeds our wedge. And one of the most difficult things about taking care of these patients is that, number one, they typically tend to have a lot of renal failure. So renal venous congestion is very common to these patients. And another thing that makes these patients really challenging to take care of is that, number one, we don't have a lot of great devices to support these patients through, and we don't have any durable devices, so any devices that we can give these patients to support them on a long-term basis. And then we have patients that have biventricular shock, and they can have various profiles that are listed up there. And so how do we define these profiles? Well, of course, we're going to use a PA catheter. And one thing that I can say is common for me is I'll get phone calls from referring cardiologists, and not usually your groups, but some referring cardiologists that tell me that they're worried about a patient, but we don't have any hemodynamic data. And so one thing that is really important is to remember to use PA catheters early and often if you're worried about a patient. Can you guys hear me okay? Now it sounds to me like I'm really loud. This is better? I have a soft voice, and I think there must be speakers up here because now I sound like I'm yelling at you, but it's a good voice level? Okay. So PA catheters, I would say, in the last years have been on the decline, so likely related to this ESCAPE trial from 2005. And who was practicing when the ESCAPE trial came out? Were any of you guys practicing in 2005? Yeah. So really changed the way that clinical medicine was practiced. From what I understand, the use of PA catheters was pretty common before the ESCAPE trial came out in critical care management. And after the ESCAPE trial came out, we saw a really steep decline in the utilization of invasive hemodynamics in taking care of our patients. And what the ESCAPE trial showed is that PA catheters used to direct decongestion in patients in the ICU didn't really change the events. There wasn't a lot of difference between the two groups. Important to note, though, that in the ESCAPE trial, these patients had an average ejection fraction of 19%, but they were normotensive. So typical blood pressure was in the 100s, so 100 and above. So not really the category of patients that we're going to be talking about today. Then I want to point this out because I think this is really important. There was a recent review of the National Readmission Database that came out that demonstrated that there were improved outcomes in patients that had PA catheters inserted. And so in this study, what they looked at is patients that were hospitalized with cardiogenic shock in a national database. And they looked at their index admission, and then they looked at whether or not these patients that were coded as having cardiogenic shock received invasive hemodynamics or not. And then they looked at the differences between the two groups. And so in the group that received no right heart catheterization, they were readmitted within 30 days. The group of survivors was also readmitted after they had a right heart cath, and then they looked at the differences between these two groups. And so they looked at the readmission rate, and what you can see is that there's not a big difference between the readmission rate of these patients, but the time to readmission was statistically different. So if you had a right heart cath, you might stay out of the hospital a little bit longer. But the utilization of other therapies in these groups was very different. So the rate of insertion of intra-aortic balloon pumps in patients that did receive a right heart catheterization was higher, as you would imagine. And then the rate that these patients went on to have ECMO, receive orthotopic heart transplant, or an LVAD was also very statistically significantly different. And so in my opinion, the reason for that is because if you don't know, you don't know. But if those bad hemodynamics are staring you in the face, you're going to feel compelled to do something. And whether that's inserting a mechanical device and then thinking about whether or not you're going to refer them on or referring them on to receive advanced therapies, really important to know what those hemodynamics are. But if you don't know them, you don't know them. And so when should patients be referred? And so there are different criteria for referral, but an easy thing to remember is the I need help mnemonic. So patients that have ever needed IV inotropes. So if your patient has needed IV inotropes, that is a really important sign that maybe you should think about referring the patient for advanced therapies. NYHA functional class 3B or 4 with very elevated natriuretic peptides. Natriuretic peptides are, of course, associated with mortality, and so if you're seeing very high natriuretic peptides, think about sending them on. Evidence of end organ dysfunction. So if patients are developing renal failure, liver failure, please send them on. An ejection fraction of less than 35%, recurrent defibrillator shocks, just one hospitalization is associated with a mortality impairment in patients with heart failure. But I would say generally greater than 2, you should really be thinking about where is this patient going. Edema despite increasing diuretics, low blood pressure and high resting heart rate, and then progressive intolerance or down titration with your guideline-directed medical therapy. So if you're having to peel back on medicines, think about where is this patient going in space and time and what should I do with them. And then of course, refractory cardiogenic shock, which is your inpatient setting patient that you're taking care of. And so again, outpatient referral, cardiogenic shock is gonna be on this list because you will have outpatients that are walking around in cardiogenic shock, which is sometimes funny to think about. Patients that have new onset heart failure, regardless of the EF, we love seeing patients like this. High-risk features such as I need help, consideration of device therapy, so patients that are on guideline-directed medical therapy that have failed other device options. We're happy to see patients for even a second opinion about the etiology of their heart failure or management of their heart failure. Sometimes we like to see patients for an annual review and then clinical trials. And so what we'd really like to have here is a collaborative care model with other cardiologists in the Valley. So that's outpatient referral. I thought I'd move on now to go over a recent case that we had, and I'll tell you that there are some images in this case that the patient gave me permission to share. So this is a 61-year-old gentleman. His only past medical history was sleep apnea. He also told us that he had gained some weight in the last year, and so some weight gain, and his BMI was probably in the 30 to 32 range, so not very heavy. Moved here recently and was attending a spin class with his wife. He and his wife decided that they wanted to work on getting in shape, and he collapsed at a spin class. EMS arrived, he was having a STEMI, and he was taken to the nearest hospital, which just happened to be our hospital, with this ECG. Pretty scary looking ECG. I would imagine even for the interventionalists in the room, it's pretty impressive. I'm not myself an interventionalist, but pretty large ST elevations in those anterior precordial leads suggestive of an acute myocardial infarction with a normal initial troponin, so he got to us really fast. This is his cath, and you can see a total occlusion of the LAD in the proximal segment there. And the rest of his vessels are patent with non-obstructive disease. He showed up in complete extremis, required emergent balloon pump placement, and was intubated for airway protection because he was having significant respiratory distress. And this is his initial echocardiogram, and you can see that he's had a very large territorial myocardial infarction, very poor ejection fraction in that anterior distribution. And so my question for the group is, what would you do at this point? How would you manage him? Who's going to take him to the cath lab and try to revascularize him? I think everyone. Yep. And then at this point, though, would you call for transfer to a quaternary care center for consideration of advanced therapies? Would anybody call at this point? Probably not. This is something that you guys take care of all the time here. And then continue to optimize hemodynamics. I'm sure that everybody here would do that. But you know, why should we think about early referral? Late referrals are something that really plague us in our center. And so late referrals have an increased risk of additional complications, such as pulmonary hypertension, right heart failure, renal failure, liver dysfunction, cardiac cachexia, et cetera. And then sometimes we have patients that come and are just overall too unwell for us to be able to resuscitate. At this point, I don't think that this gentleman warranted any consideration for referral if he was at a different center. I think that this is something that you guys see on a very routine basis. But when we think about our patients and when we want to take care of them, we really do want to see patients early, if possible, after they've been revascularized, after you've done all of the things that you can do if they continue to slide. And the reason we want to see them as early as possible is because that gives us so many more opportunities to take care of them before they're really with irreversible dysfunction, irreversible frailty, or irreversible end organ dysfunction. And mortality remains high for this patient. So everybody knows that this patient's mortality is incredibly high. So we had a 2021 update to the 2017 expert consensus decision-making pathway for optimization of heart failure. And there were answers to 10 pivotal issues about heart failure. I really like this document. I think it talks a lot about things that are important for advanced heart failure. But one of the things that this document really says is that appropriate and timely referral to a heart failure specialist and/or heart failure program is essential in selected patients to optimize therapies and evaluate for advanced heart failure therapies. We also got some consensus recommendations for heart failure from the Heart Failure Society of America on how to take care of stage D patients. This is written by some people that I've worked with in my training and people that I know very well. And what they say here is that in the spectrum of your heart failure, you should think about taking care of your heart failure patients, optimizing them medically, surgically, using all of the device-based therapies that are available to you at your center, and then continue on with regular surveillance, but that you should look for advanced heart failure triggers and then consider referral if patients meet those advanced heart failure triggers for consideration of cardiac transplant, DT LVAD, and investigational therapies. Again, we went over these triggers, really important to remember these and think of them often. We talked a little bit about invasive hemodynamics, and so in patients with cardiogenic shock and that are hospitalized, we do have some data about mortality. So this pertains to this patient. I think this is a really telling graph that I think we should probably all put in our heads. This is SCAI mortality, and it's in-hospital mortality of patients with cardiogenic shock. And so the gray bars are all comers with cardiogenic shock. And you can see that there's a significant survival deficit for patients that are showing up in the later stages of shock. So if they're the stage C patients that we all see kind of on a daily basis, their mortality is less than 20%. For those deteriorating patients, mortality is getting closer to 40%. And for those patients that show up to us in extremis, their mortality reaches 60%. And there are some differences between patients that show up with acute myocardial infarctions, those are the green bars, and patients that show up with progressive heart failure. And you can see that when you get to stage E, whether you have an acute myocardial infarction or progressive heart failure, mortality, again, very high. But interestingly, for patients that are in that stage D with chronic heart failure, they seem to have a little bit better mortality than those who are showing up with acute myocardial infarction. And so our patient that we're talking about today, he's in this group here, so he's showing up deteriorating, very high mortality for him. Also in this study, they looked at the differences between people that survived versus people that did not survive their episode of cardiogenic shock and the hemodynamic differences. What you can see here is that patients that were a little bit older did worse, as we would expect. Patients that had worsening end organ dysfunction tended to be in the non-survivor group. So if your lactate is elevated, if your serum creatinine is elevated, those patients tended to be in the non-survivor group. But interestingly, when they looked at the hemodynamic data, the thing that was strongly correlated with how these patients did over time is evidence of congestion. So I think that this is really interesting. So the more congested a patient is, the worse they're going to do. And what you can see is that in the survivor group, the mean RA pressure on average was around 13 millimeters of mercury. And at 16 millimeters of mercury, those patients in the non-survivor group did worse. And so patients that are congested tended to do worse. Also, patients with lower blood pressure tended to do worse on average. So the people that showed up with the lower mean arterial pressures tended to end up in that non-survivor group. And so if you have a patient that's showing up to you in cardiogenic shock and you're thinking, should I get them started on an inotrope? Yes, you should, if you think that it's going to improve their hemodynamics. But really important to remember that inotropes don't save lives. So it's something that we can use to bridge patients to the next step or to get them decongested. But even if you're just using them to decongest patients, you need to think about, where do I go with this patient next? And so this was a single center study from Canada where the primary endpoint was in-hospital death, resuscitated cardiac arrest, cardiac transplant, MCS, non-fatal MI, TIA, or that's supposed to say stroke after that, or the need for renal replacement therapy. Interesting to note here, I've had some colleagues that have told me that they think there are significant differences between dobutamine and milrinone. Really no significant differences between the two, but you can see that 50% of these patients will have some kind of very clinically significant event within 10 days. So very important, inotropes don't save lives. They should really be used as either palliation if you decided that they're not a candidate for advanced therapies, or to get you onto your advanced therapies pathway. And so how much has been talked about in these sessions about device-based therapies and things like that? Has it been a lot? Yes. So I won't spend a lot of time going over this because I'm sure that this has been well reviewed at this point. But suffice it to say, very important to define the type of shock before you choose your devices and your support, and then support based on the type of shock that you have. And this is just a blown up version of this so that you can see it a little bit better, and then which devices should you use. And in your centers, do you have access to Impella 5.5s? Yes. Are you using them often? Not very often, not very often. And does surgery put them in for you, or is it the interventionalist? Yes. Okay, so we also use a lot of Impella 5.5s. We use them as a bridge, so we put them in patients to get them safely to transplant. We typically don't use them as a bridge to get them to LVAD, although we have used that in the past. Typically, we don't need to use that too often. They're a great bridge to get patients to transplant. And how about the right-sided devices? Do you have ProTech in your system? Yes. And then how about Impella RPs? Not yet. I'll tell you, you already have the better device, in my opinion. The Impella RPs are very positional, challenging to use, and I would say the ProTech's a great device. So if you already have that one, I think it's a kind of better device for support. Anyhow, and again, that's an opinion-driven statement. So for temporary MCS, timing matters. We want to make sure that we're supporting these patients in as timely a fashion as possible to avoid an organ dysfunction. And then contraindications to temporary MCS, these are actually contraindications to other advanced therapies as well. So moribund state, intracranial hemorrhage, brain death, no exit strategy. So if we don't have anywhere to go for the patient, that's not a good option. Illness likely to result in shortened life expectancy, something like ALS or cancer. Although our paradigm with cancer has really been changing. We think about cancer a lot differently than we used to in the past in terms of transplant candidacy or even LVAD candidacy now. And then there are other device-specific contraindications, things that would bias you one way or another, things like LV thrombus, severe PAD, or aortic insufficiency. So what happened to our gentleman? He shows up, he is getting worse, actually. So we repeat the left heart cath to see what's going on. It turns out his stent is patent, and he ended up getting an Impella 5.5. 6 days later, he had recurrent VTVF, was very unstable despite the Impella 5.5, and then we ended up having to place emergent ECMO on this patient. 7 days later, we had him listed for transplant, and he received a heart transplant at our center. So we were fortunately able to get him to transplant safely after this very acute event with a very short illness. And this is his explant, and what you can see here is that the left ventricle has sustained a very large, full-thickness myocardial infarction, and that LAD territory was very significant. You can see that it affects a big portion of the myocardium. And so I'm going to pivot a little bit and talk to you now about some advances in advanced heart failure therapies, some things that I think you might find interesting about what we're doing and how we're taking care of patients these days. And so what advanced heart failure therapy options do we have for patients? So when patients reach the end of the road with their heart failure, what can we do for them? So we can do heart transplant. We can do mechanical circulatory support, specifically durable LVAD therapy, and we can do palliative care in hospice. And because it's a shock symposium and I wanted to talk a little bit more about, some transplant and LVAD stuff, I'm not going to talk about palliative care in hospice in this talk, but I'll tell you this is something I'm incredibly passionate about. I love talking about this, and so if anybody ever wants to hear a talk about this, I can talk for a full hour about this. But what are the indications for transplant or durable LVAD? So criteria for LVAD, CMS tells us that it needs to be a patient that has NYHA functional class 4 symptoms, so highly symptomatic patients, symptoms at rest. They have to have an ejection fraction of less than 25%. They have to be either inotrope dependent or have a cardiac index at rest of less than 2.2 while not on inotropes. And they have to have one of the following. They either have to have failed optimal medical therapy for 45 out of 60 days. I find this to be such a bizarre criteria. Nobody ever counts those days and decides how many days they've failed out of. It's just, are they failing or are they not? But they have to have advanced or acute heart failure for 14 days preceding your decision or have to be MCS dependent for 7 days. And so this is a very specific set of criteria that we do have to document well when we're implanting an LVAD. And what are the criteria for transplant? So cardiogenic shock requiring inotropic support or temporary MCS, persistent class 4 symptoms despite optimal medical therapy. If they're intolerant to beta blockers, they have to have a cardiopulmonary exercise test, peak VO2 of less than 14. If they are on a beta blocker, that needs to be less than 12. And for some patients who are young, they seem to have these really good peak VO2s because they're young, they're otherwise healthy, they have strong bodies. And so sometimes if they have a higher VO2 than our typical cutoff for transplant, we'll look at how they compare to their peers. And if they're less than 50% of where they should be, we can consider those patients too. So another thing that we look at that actually has good survival data is the VE/VCO2 slope, and if that's greater than 35, those patients really do have a significant mortality impairment. Refractory angina is also a criteria that we can use to list people for transplant. So if you have patients that have Canadian class 4 angina, refractory to all of the stenting and everything that you've done in terms of up-titration of anti-anginals, et cetera, that is something that you can get listed for heart transplant for, and a lot of people don't know that. And then, of course, refractory arrhythmias, so people that are having recurrent VT-VF, even if they happen to have a normal ejection fraction, if that's a life-threatening situation for them, then we can get them listed for transplant as well. And so I'll tell you a little bit about cardiac transplantation. The first heart transplant happened in 1967 in South Africa by a surgeon named Christian Barnard. The patient was named Lou Washansky, and he lived for 18 days. Has anybody ever read the book Every Second Counts? Yeah, great book about the history of transplantation, very interesting, and about the theft of intellectual property. But anyhow, it's widely believed that he stole the technology that Americans were working on, brought it to South Africa, and then became the first person to do a transplant. The second patient that he did actually lived 2 years. And then heart transplant was initially very exciting to people, but we didn't have medical therapy to help take care of patients after transplant. And so then enthusiasm waned for a while until the 1980s when cyclosporin was invented. And that was a huge advancement for heart transplant technology. It allowed us to take care of patients and suppress rejection better than we had been able to in the past. And what is going on in the modern era of transplantation? So some of the things that hinder our ability to be able to offer this therapy more include limited donor pool, and then balancing the needs of immunosuppression with infection and ultimately cancer later in life. And so heart transplant has been on the rise. In 2021, we did 3,800 heart transplants in this country. And you can see that there's been a big upslope in transplantation after it had been fairly stagnant for a while. And to what do we owe this? I'm going to go forward a little bit. I'll talk about what we owe that to in the next couple of slides. And what is our median survival? So our median survival, and this is graft survival, not patient survival, is 12 and a half years for an adult heart transplant. And the reason that I say graft survival instead of patient survival is because we do have some patients that will have more than one transplant in their life. So we'll have young patients that will come in for a second transplant, even a third transplant. We did a third time redo this year in a very young patient who had premature graft failure. So median survival of the graft is about 12 and a half years. And when patients come in, they'll often say to me, does that mean I'm going to die in 12 and a half years? And I say, no, it doesn't mean that you're going to die in 12 and a half years. And I'll talk to them a little bit about the differences in graft survival. But important to know here, too, that we transplant people at a wide variety of ages. So starting at 18 all the way up to 70. And so the baseline life expectancy for somebody that's 70 years old is very, very different than somebody who's 18 years old. So this is our data, and this is the national data, and I can tell you a little bit about our data in subsequent slides. In 2018, the UNOS changed the way that hearts were allocated in this country, and it really changed the way our practice is. What they wanted to do is they wanted to differentiate how sick patients were. In the past, we only had 3 statuses, and now we have 7. And so it really wanted to prioritize the most critical patients and then promote equity for distribution of organs. So now, like I said, we have 7 statuses. Status 1 is somebody that is moribund. So they're on ECMO, they cannot be weaned from ECMO, and they get the highest priority. We have status 2 patients, and interestingly, there is a lot of variability in status 2 patients. So this can be a patient that's supported on a balloon pump and kind of doing okay on a balloon pump, all the way up to somebody that is supported with a ProTech and an Impella 5.5, so that's really a lot more support, and they all fall into this status 2 category. I think that there needs to be more differentiation personally within the status 2 category. Status 3 patients are people that are on multiple inotropes or a high-dose single inotrope with invasive hemodynamic monitoring, or patients that have a dischargeable LVAD that get 30 days of this status 3 time that can be used at our discretion. Status 4 are ambulatory inotrope patients, and then we get some special exceptions in this group for people with kind of unique cardiomyopathies, things like amyloid, restrictive cardiomyopathies, congenital heart disease, or retransplant patients. Status 5 patients are people that need multi-organ transplants, so that's things like heart kidney or heart liver. And then status 6 is an ambulatory patient that's okay on just medicines alone. Status 7 are patients that are inactive on the list. And when this changed, it really changed how organs were allocated. It also changed how sick patients are going into transplant and really helped prioritize those sick patients. So in the past, in our allocation system, somebody on a balloon pump was the same as somebody on ECMO. Obviously, you can imagine that somebody on ECMO is much sicker than somebody that's on a balloon pump, and we ended up losing patients that were at the top of the list, listed status 1, because there was no separation between those 2 things. Now we get separation, and you can see that patients on ECMO represent still a small portion, but a significant portion, almost 10% there. Status 2s are the majority of patients that get transplanted, followed by status 4s, interestingly, and then status 3. And as we saw this allocation system change, we actually saw an increased utilization of balloon pumps in the community, and then increase in exceptions, and then we saw an increased use of ECMO and people getting transplanted off of ECMO. Despite the fact that we're transplanting sicker patients, our 1-year survival nationwide has remained fairly similar, which is good, but our length of stays are longer. I'm going to go back. And so I showed you that graph that showed how the number of heart transplants has been increasing in this country, and to what do we owe that? So the main goal here has been to increase the donor pool. So we have a tiny pool here. You can imagine this is in your backyard. You'd really like to have a larger pool. We would like to have a larger pool of organs available for our patients as well. So we'd like to go from that small backyard pool to this, where we have lots of space and lots of options. There have been a few innovations that have been really helpful for this. So hepatitis C positive donation. In the past, we did not have good therapies to treat hepatitis C. Now we have essentially universally curative therapies for hepatitis C, which means that we can take hearts from patients that have hepatitis C and are even actively viremic. We treat them with antiviral agents right out of the gate. They often do not have any viremia or any changes or perturbations in their liver functions, and they have great outcomes. This has increased the donor pool, not as much as we would have wanted, but by about 3% nationwide. And what we're seeing now is that approximately 10% of our donors are now hep C positive. The next thing that's really increasing our donor pool that's really important to talk about is something called DCD transplantation. So is anybody familiar with this? Yeah? How do you guys know about that? Oh, okay, great. Oh, and I know you. Hi, nice to see you. Yeah. Okay, so DCD transplantation. So DCD stands for donation after circulatory death. Our traditional donors have come from patients that experience brain death, which is a very specific injury pattern, and is, really limits the number of donors that are available to us. DCD, so donation after circulatory death, means that the donor's heart has stopped beating from another cause, another non-cardiac cause, and we're able to take the heart out of that donor and give it to a recipient. We use a device called a transmedic device, and so what we do is we wait for the heart to stop beating. There is something called standoff time, which means that the patient has to be officially dead for a certain amount of time before you can procure the organ. And that is set regionally and locally, and so we don't have a lot of control over that, although we might be seeing some legislation coming through that will start regulating that. Typical is around 5 to 10 minutes, and so the team is available on standby. They wait for the appropriate amount of standoff time, and then they procure the heart and put it into this transmedic device. It's really interesting. They perfuse it with donor blood, and the heart reanimates and starts beating again. We then can transport that heart anywhere that we need to. We can monitor the heart via different mechanisms, and then eventually transport the heart. And what we're hoping is that this will increase our donor pool very significantly. So whereas our hepatitis C positive donors increased our donor pool by around 3%, we're thinking that this is going to increase the donor pool by upwards of 40%. So a really significant increase. And this is the first DCD transplanted heart that we did at Mayo Clinic in Arizona. We did it in the fall. This is the heart after we put it on the transmedic device, and you can see that it wakes up and it starts pumping again. The interesting thing to know about this is that in our experience, there is a higher need for mechanical circulatory support after this type of transplant. Usually the acute injury, which we think is a lactate buildup in the heart and some, stunning, resolved after about 4 days. And if you look out to 30 days and 1 year, the survival curves for patients that have received these types of transplants are very similar to DBD or donation after brain death patients. And so what we're seeing is that the number of heart transplants is on the rise in this country, and the little green bars down there are the number of DCD transplants that are being done in this country. The first one was done in 2019 under clinical trial, and that's been going up steadily every year since. These are some papers that talk about the different experiences with DCD, and again, I don't want to belabor this too much, but it is a little bit more labor intensive. There's a line there that says severe PGD, which is primary graft dysfunction, and these people tend to have more PGD than our typical DBD patients. Another thing that we're doing is multi-organ transplant, and so this is a heart, kidney, and a liver, and so at our center we are able to offer both heart, kidney, and heart, liver, and our experience has been good. We haven't done a lot of heart, liver patients. Interestingly, the liver patients either show up and they don't actually need a liver when we biopsy them because the liver regenerates. You can have very advanced liver failure and not actually need a liver transplant at the same time as heart transplant, or they tend to show up too late, too sick, and just tend not to be candidates. So it's hard to find people in that sweet spot, but we do combined heart-liver, and we've had good outcomes with that. We do a lot of combined heart-kidneys. The kidneys are often the canary in the coal mine when patients are doing poorly with heart failure. I had an attending when I was in fellowship that called the kidney nature's quitter. So I thought that was pretty cute, but about 20% of our volume is combined heart-kidney, and our experience mirrors this one where heart and kidney transplant combined tends to have similar outcomes. The situations where they don't have similar outcomes, there's people that have been on long-standing dialysis. So if you have kidney failure first and then you get heart failure, those people tend to not do as well, and probably related to the fact that being on dialysis, having advanced kidney disease really is very hard on the rest of the body. And then we did our first heart, liver, kidney transplant this year. This is our patient Doyle Duke, excuse me, and he's on the news, so we have permission to talk about him too. Really great patient. He has a restrictive cardiomyopathy, struggled with it for a lot of years, ended up getting amiodarone liver toxicity, developing cirrhosis from congestive hepatopathy and also amiodarone, and then subsequently renal failure as well. So we transplanted him, and he was our first heart, liver, kidney. He was the first heart, liver, kidney in the state of Arizona. And what are our outcomes like? We have really great outcomes at our center, and I just want to brag on my program for a second. We have some of the best survival in the country in terms of 1 year and 3 year survival, and our 3 year survival is 95% for our patients. This is risk adjusted, and so we do get points for taking higher risk patients. So these are, I've had people say to me, that's because you cherry pick patients, but we take very sick patients and have really strong outcomes. So I think we all feel really good about that. So 95% at 3 years. I'll talk a little bit now about left ventricular assist devices. Left ventricular assist devices have come a long way in the last 20 years. Let's see. Oh gosh, I think the wrong picture came through here. Yeah, it's backwards. Anyhow, has anybody in this room ever taken care of an XVE or seen an XVE, our first generation pumps? Anybody seen those? I'm sorry, the picture's behind here, so I'll just kind of show you. So the first generation pumps were pneumatically driven, very loud in the patient's room, so you would hear choo, 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 choo. I've actually never seen these pumps in person or utilized in a patient. They were enormous. So the XVE is about this big around. Would not have fit into an adult my size, and so you could not put them into very small patients. They were actually implanted in the abdomen, and the pump itself, it's very heavy if you've ever felt one. It sat right on top of the stomach. People developed really significant cachexia as a result, weren't able to stay nourished when they were on this pump, and they had a very predictable fail rate of around 14 months. So we could bridge patients through for about 14 months before those devices would fail. Our second generation pumps were axial flow devices, non-pulsatile or continuous flow. That's the HeartMate 2. I'm sure a lot of you have seen the HeartMate 2. That was a big step up, and we've had patients on support on those devices for a long time. The problem with those pumps is that they had a high thrombosis rate, so they would clot off if you had perturbations in your anticoagulation, and sometimes even if you hadn't. And so that was a big problem with those types of pumps. We're on to our third generation of pumps and have had some really big advancements. We only have one FDA-approved pump right now for the entire country, and that's the HeartMate 3. It's a great pump. And so what you can see is that over the last 20 years, the technology has really advanced. We have much smaller pumps now. That's a pump in somebody's hand. It's a magnetically levitated, self-centering device that is a centrifugal pump, so it spins and pushes blood out at a 90-degree angle. And it has built-in pulsatility, so it ramps up its speed and down its speed about every 2 seconds. Because of that, you can feel a pulse in the patient if they don't have their own intrinsic pulse. That pulsatility is really important because it actually washes the internal mechanism of the pump and has been associated with a much lower stroke rate and thrombosis rate for these patients. So it's our only device. It works very well, has significantly superior outcomes to our previous generation pumps, and has very good survival. This is our data at our center. We have a very low rate of GI bleeding now, so much lower. You can see that our goal there, this is the top right corner, is to have GI bleeding rates of less than 20%, and our patients were well below that. And in the era that we've been doing this, we've just seen a steady decline in our GI bleeding. Length of stay is about stable compared to our previous generation pumps. Our average length of stay is about 17 days post-implant for our LVAD. It's 11 for a transplant. For hospitalizations, these patients used to have very frequent recurrent hospitalizations, and you can see that our hospitalization curve is going down there, and we're seeing fewer hospitalizations, which is really important for quality of life, especially for our destination therapy patients. Driveline infections remain stable. They happen. And then you can see this is our Kaplan-Meier survival curve for our center. We're at 87% 2-year survival for our LVAD patients. They have very good survival. And to sum it up, so this is the American Heart Association walk, and this is our patient, that first patient that you met that ultimately got transplanted off of ECMO. He's now 5 months post, participated in the heart walk, and is doing really well. He's back at work and loving life. Huh? Him? Oh, he's, yeah, maybe. He looks pretty good. You don't want him too skinny after transplant because they need to have a little bit of reserve. So what do we do when things go wrong? I think we all have our natural defense mechanisms. I tend to lean towards more coffee, although I wish I could clone myself. Feigned death sometimes seems appropriate in the hospital, denial. But I'd like to implore you to please call heart failure if things aren't going well. And so again, refer early if you're able to. We do have advanced options. Transplant technology and LVAD technology continues to progress, and we can do a lot of great things for patients. And I'll leave you with our slide. These are my wonderful partners who I love so much. And in the last couple of years, we now have a heart failure hotline that I would like to leave you all with. So this will put you directly in contact with the heart failure cardiologist on call. It switches with our call cycle, so you never have to worry about calling the wrong person at 3 o'clock in the morning. It'll go directly to our cell phone. And that number is 480-57-HEART. And we love to hear from people, even if you have a question or, just something that you want to chat with us about, run by us. We're happy to talk anytime. I also have included all of our personal cell phone numbers and our email addresses up there. So, thank you.
Comprehensive talk. The question is just in my mind related to this specific, conference. To me, it seems like the cardiogenic shock C and D is the most problematic, especially given the variation of the mortality.
Yeah.
And I'm wondering, what do you use a criteria to say, I want to escalate in this C or D type of patients my therapy? And when you decide that, do you depend on to improve the hemodynamic, or do you depend on some data that provide you with better clinical outcome?
Yeah, I think this is a really great question. And highlights a really important point. So for your cardiogenic shock management patients, you have a lot of therapies at your center to help support these patients. You have a lot of tools to be able to take care of them. What I would say is that you implement therapy and then you reassess. And I personally think the best way to reassess is with ongoing hemodynamic data, and that coupling that with your end organ function is really important. So if you've escalated therapy, patients not getting better, then that's a great sign that you should send them on. Even if you have other things that you can do for the patient, if you're thinking, gosh, I really need to reach for that Impella 5.5, then I think that the next thought is, what do I do after that? For us, with our ECMO patients and our patients that are on MCS that we think are not going to recover, which is really a lot of these patients, we're already starting to think, what are the next steps? But important to say that, especially for our ECMO patients, those patients, the clock starts ticking right away when you put that in. And so when you're on ECMO, the longer you're on ECMO, the more likely you are to develop an ECMO-related complication that could impair your ability to move forward with transplant. And so once you get into those really advanced devices, think, what do I do from here? Where does my patient go? And for me, as a receiving physician on the other end of those things, I would so much rather have a patient come to me early that maybe gets better and leaves the hospital than somebody that comes a little bit too late and then you're really trying to play catch up. So I think that if you're managing the patient, they're getting better, great. Keep managing the patient, but also still think, somebody that's been on an inotrope or MCS at some point may need to go on to advanced therapies. But if they're in your center, they're doing better, they're improving, I think, keep managing them and think about, next steps later. If they're not getting better, we would much rather have an early phone call about a patient than a late phone call. And I think hemodynamic data is really essential when you're managing these patients.
Any questions from the audience?
Thank you very much for a great, excellent talk. I enjoyed it. Is there any change nowadays in the upper limit of age for patients to be accepted for transplant? And the second question, post-transplant, do you guys have any specific diet or nutritional requirements that you guys follow?
Did you say he's the vegan?
So be careful before you answer.
Sorry, ask me the first part of your question again, age limit, right? Yeah, so we don't have an official age cutoff at our center, although I will say that 70 is a number that we think of a lot. Once you're above 70, it's really hard to make it to being above the age of 70 with significant disease that has led to terminal heart failure and not start acquiring some other medical problems along the way. But for patients that are 70 and older that are really otherwise pretty good medical candidates that are not frail, we will consider in special circumstances people over the age of 70. So no official age cutoff, but it's just hard to be a good candidate over the age of 70. The second part of your question is after transplant, is there any specific diet that we recommend? And the answer to that question is no. Oftentimes when patients come to us, they have cardiac cachexia and they're malnourished. So malnutrition, even in the setting of obesity, is really common for our patients. And so after transplant, a lot of the medicines that we use can affect their sense of taste. They're really sick. They're coming into it cachectic to begin with. And so we try not to be very restrictive with them afterwards and say, just eat whatever sounds good. Eventually, we'd like them to maintain a healthful diet. A lot of these people actually get diabetes post-transplant if they didn't have it pre-transplant. And so I would say that a Mediterranean or a plant-based diet would be a great diet. The reason for diabetes post-transplant is because, number one, end-stage heart failure has a higher association with diabetes, and number two, our calcineurin inhibitors actually lead to the development of diabetes. And so tacrolimus and also cyclosporin can lead to patients developing diabetes, and then we also give a lot of steroids, so there's hyperglycemia associated with steroids as well.
When do you decide about LVAD versus the transplant? And when somebody is on LVAD, how is your success rate that they don't require transplant?
Great question. So in the new allocation system, unfortunately, patients with durable LVADs are at a significant disadvantage compared to other patients on the list. So they have a much lower priority. So they're listed as a status 4 if they're on the list. And then they get this, what we call discretionary 30-day time, where they get 30 days to be at a higher listing status to see if we can get them a transplant. We try to be very specific about when we use that time to make sure that they're not competing with other recipients, and that, you know, we're able to try to maximize their opportunity to get a transplant. We have really great survival for patients with LVADs. So if you're not a candidate for transplant and you end up getting an LVAD, those patients can do very well on mechanical support for a long time. But if you are a transplant candidate, we will try to get patients transplanted out of the gate because we know that the likelihood that they're going to get transplanted off of an LVAD now is less. So we really try hard to get them transplanted out of the gate, rather than in the past we used to do LVAD as kind of a better bridging strategy. In the new allocation system, they just don't get as good a prioritization, so it's less of a good bridging strategy. But, you know, for patients that are candidates for transplant that do end up getting an LVAD, we only get a certain amount of time to have them at a certain listing status before we can implant an LVAD. So if they don't get a transplant, end up going on to LVAD, and then we try to get them transplanted later, we have a good success rate of getting them safely to LVAD. In the future, I think there's going to be a lot of discussion about how we get patients to transplant and how we implement MCS, because the outcomes for durable LVADs are getting so good that it really does approximate transplant at some centers. In our center, our survival is clearly better with a transplant than an LVAD, but at a lot of centers, they're more comparable.
Of the LVAD have increased. I mean, my last look at the statistic, the adoption of the LVAD did not increase much.
No, and we've actually seen a decline.
So good?
Yeah, we've actually seen a decline. So I think there are a number of problems that lead to that. Number one is under referral. So I think a lot of cardiologists trained in the era where LVADs were not good. They saw those XVEs that only lasted 14 months, or the HeartMate 2s where patients had really frequent readmission rates, lots of GI bleeding, strokes, and I think that really leaves an indelible impression on cardiologists, and they think, why would I want to send my patient for that? What I can say is that patients have usually a very significant improvement in their quality of life and definitely a survival benefit, but I think one of the biggest issues is under referral. And then the allocation system disadvantaging them has also led to decreased utilization as well.
So that's really the same question that I asked before the first question. Do we have a clinical data to keep upgrading, or we need to generate data to find what patient benefit from what the most? What stage we are in terms of the scientific path?
If you have irreversible stage C heart failure, they should go on to advanced therapies. So even if they're getting better on the therapy that you have, but this is a burnt out ischemic cardiomyopathy that's never going to get better, move that patient on. So I think what I would mostly think about is what happens to this patient next, and ask yourself that question. So even if they're getting better on your therapy, you're going to think, where are they going to go from here? And kind of make a decision based on that.
A couple of quick questions before we move on to the next talk. So if the patient is eligible for multi-organ transplant, heart,
Yes.
liver, heart, kidney, do they jump the line for the transplant? They stay at the same tier?
It turns out no. So he was asking if a patient is eligible for multi-organ transplant, do they get a higher prioritization? So the answer is no. If they were just a status 6 patient waiting for a heart and a kidney, they would get to go up to a status 5 for that. But otherwise, their listing status is based on the type of support that you're needing to support them. So even if it's a heart, liver, or heart, kidney, or heart, liver, kidney, our patient that ended up getting the heart, liver, kidney was supported off of high-dose inotropes, and we had him, I believe, listed as a status 2 by exception when he got transplanted, but they don't get a higher listing status for multi-organ failure.
Catheterization on patients who are, deceased patients who are expected to be donors. What is the role of the right heart catheterization in a prospective donor patient?
It can tell us how well the right ventricle is doing, and that turns out to be really important. So a lot of post-transplant management for us is managing the RV. The right ventricle tends to be very sensitive to ischemic injury that happens at the time of transplant, and so we want to know how the right ventricle is doing. I think it's data that we look at, and it's useful to us, and we appreciate the centers that give us that data. It's incredible, right? It's really important to be able to participate in donation, both with organ procurement, which is what you're doing there, and being on the receiving end. So I just want to say, number one, thank you for your efforts. And number two, it's really to look at that RV, which tends to be very sensitive and requires specialized management after transplant.
Thank you so much for being so kind to us on a Sunday morning, leaving your children and coming here. That one, again, great talk. And so how many HeartMate 3 do you have in your practice?
We follow about 50 to 75 patients on support. Not all of those patients were implanted at our center, so sometimes we have patients that leave our center and go to live somewhere else. And sometimes we have people that come here to Arizona to live that somebody else has implanted. I would say that usually ends up being a net neutral, and so we have about 50 patients on support right now. The most interesting thing about LVAD survival data is that it's hard to get good LVAD survival data because we cull people out of the LVAD population that are healthy to transplant them. So we wouldn't know how long they would actually live on support, but we have had patients on very long amounts of support. We've had patients that have been greater than 12 years on support. So we have patients that have lived for really long periods of time on LVADs.
LVAD patient, if you happen to come across, God forbid, in a general cardiology practice, what are the things which a general cardiologist should know about LVAD care?
Yeah, really good question. So LVAD care is really specialized. Most of the LVAD patients that we take care of don't share care with their primary cardiologist, mostly because even taking their blood pressure is different, and they can't be hospitalized in centers that can't take care of LVADs. So it is something that we talk about a lot, because I think that one of the things that I think is hard is for you've taken care of these patients for long periods of time, for years and years and years sometimes, before they end up coming to us, and then they end up staying at our center afterwards. And one question that I would put back to your group is sharing LVAD patients or doing some shared care models with those patients something that your group or your team would be interested in?
But we don't know how far we can go. So we would love to. I think in the sense that we would like to know more about heart failure is spectrum, and see how they eventually do, because there's also a common misconception that once your patient gets LVAD, then he's not going to get heart transplant ever. So that's also, I mean, you clarified that point.
I think that it's not true that they won't get transplanted ever, but if we can transplant them out of the gate, we try to. The new allocation system does make it a bit more challenging, but it's not that we never do it. One of the things that should hopefully change that is DCD transplant in the future and expanding that donor pool. The LVAD population is a perfect population to help apply that to help them get transplanted more frequently.
In the pipeline.
Yes, really good question. So with HeartMate 3, the external experience of the device for the patient is the same, essentially, as the HeartMate 2. So we didn't really get big advances in terms of what's on the outside of their body. What's on the inside of the body is much, much better, and their quality of life should be better because they're having less frequent hospitalizations, GI bleeding, strokes, etc. But the outside experience for the patient is really hard. They still have to be attached to either battery or wall power 100% of the time. They still have a driveline that's tunneled outside their belly, so they have a power cord that's tunneled outside their belly and attached to their patient monitor and also their batteries, right? So they can't submerge in water.
No Tesla chargers?
Right, and so what the biggest barrier has been for internalization of all of that stuff has been getting the charge, right? So our pacemaker batteries are really small, we can just replace them. But to transfer that much energy from the outside of the body into the inside of the body creates heat and requires a lot of surface. And so that's been the biggest barrier to making it a better experience for patients. And so internalization of those things, I would say internalization and the patient experience with their device is going to be, I think, what the companies are going to be working on in the future to make it more forgettable for the patient.
Biggest heart transplant patient that you've seen? I used to have one in Lake Havasu 27 years out.
Yeah, around 30 years. So we take care of patients in our program that have been transplanted for 30 years or so. And our center has been around since 2005. That's when we did our first transplant. So, and we do have our patient number one, who is a lovely lady who's unfortunately gotten dementia. She's very pleasantly demented. Patient number one for us is still alive and does still come back to our center, and she gets admitted for non-transplant related issues now. So we take care of her into her golden years.
For your time, and this was really a fantastic overview of literally advanced heart failure. Moving on, we're gonna Dr. Chris Roach. Most of us know him here. He's our intensivist, and he's gonna geek us out today with the Harvey loops.
More geeking out.
Yeah.
It's like a 500 megabyte presentation, so it crashed my computer quite a few times, and I was worried that it wouldn't work out. So I'm trying to make this as yeah. I'm going to try to make this. Oh yeah, now it's on. There'll be a quiz at the end, okay? So hopefully this is more interactive. We can, I'll maybe call on people and ask to help identify some things.
But I think it's a good way to approach devices and understand in a different way to digest why we do what we do with respect to cardiovascular devices. So we'll talk about what the Harvey loop looks like with normal LV function, and then how we can augment that with different devices and how it changes with different devices. So this software, I didn't know this existed. I always know PV loops. I was asked to do Harvey loops, and I don't even know what Harvey loops, what they were when I was asked to do this talk. So when I started diving into it, there's this whole software suite developed to, I mean, you can put norepinephrine at 1,000 if you wanted to, and it'll show you a Harvey loop, what that looks like. And you can do all kinds of hemodynamic devices, medications, and it will show you what happens when you apply those variables. And this is kind of what it looks like. It's crazy. It gives you all the pressures and volumes and everything like that. Calculations here. It's quite overwhelming at first, but it's pretty robust, as you can see. So this is a normal left ventricle here. And we'll start, I guess, at this point, end of diastole here in the beginning of the isovolumetric contraction. This is when your mitral valve is going to close, right? So your left ventricular begins squeezing here until the point where the aortic valve opens, and then you have left ventricular blood ejection, aortic valve closure all the way up there, and then you have relaxation here, and this is when the mitral valve opens here to start filling the left ventricle. These curves here, does anyone know what this is? Yeah, so, and this is the systolic pulmonary pressure volume relationship curve. And that slope will tell us something about contractility of the heart, right? So the steeper the slope, the more vertical it becomes, the more contractility it is. So dobutamine, milrinone, those kinds of things, those will increase the steepness of this curve. And then if you have negative contractility, maybe heart failure, some sort of beta blockade, negative inotropic agent on board, it'll actually shift it downwards. So that's our inotropic curve there. This is the end diastolic pressure volume relationship. And another way to say it would be lusitropy, right? So your diastolic failure patients have a stiff ventricle. It's a poorly compliant ventricle, meaning it doesn't fill well with blood. In that case, in those diastolic failure patients, that will start to shift upwards, whereas it will shift downwards with a lusitropic agent like a nitrate. I don't think we have levosimendan in the United States, but that's a lusitropic agent which will relax the myocardium and allow for filling. So this is a acute LV failure. Sure, yeah.
Can you comment area under the curve for the loop? What does that represent? The width of the loop?
The width, oh yeah, I'm sorry, that's a great point. So does anybody know that? Answer that question? Stroke volume, great, okay. And obviously the wider the curve, the wider the loop, the more stroke volume you have, the narrower, the less of a stroke volume you have.
And the triangle in the left represents the efficiency or the wastage of energy of the heart pump. So the bigger the triangle in the left gets, so that triangle is the energy lost. So that represents the efficiency of the heart muscle as an engine pump. So if the triangle gets bigger, the heart is actually consuming more oxygen.
Great point, thank you. Yeah, thanks for adding that. Can somebody tell me what's going on here? Tell me what you're seeing. We have the normal curve here, the normal loop, I should say, in green. And then how has that changed?
I'm going to pick on somebody in particular. Dr. Mark Bowie.
You already commented on it. Obviously, you said the higher the curve is, the better the contractility. The more right shifted, the lower the contractility. So we have a ventricle that's at the lower contractility. Obviously, the lower part of the curve also reflects the diastolic pressure. So it's working at a higher diastolic pressure, and the whole curve or the stroke volume is narrower. So we have a lower stroke volume.
Exactly. Yeah, great point. And to your point, the triangle is quite a bit bigger. So there's a lot of wasted energy here in the heart. So obviously much less stroke volume, as you'd pointed out, and of course, the pressure-volume relationship of the inotropic curve is greatly reduced.
Why it shifted to the right?
Simply, well, inotropy, right? So the curve is brought down significantly from reduced inotropy, right? And your volume, again, on the bottom is the volume and up top is the pressure. So your end diastolic volume is quite a bit higher as well. So you're ejecting physically quite a bit less blood. Does that answer your question?
Gone down by at least 50%, which has decreased your stroke volume, increased your end diastolic volume, increased your end diastolic pressure.
Yeah.
So this is acute heart failure from loss of contractility.
Yeah, exactly. And you can see the compensatory mechanism here: increased heart rate, your blood pressure, your pulse pressure is arguably getting narrower. You can see your PA diastolic pressure here of 30, indicating that you have a higher, well, assuming pressure and volume are the same thing, which I think is a bit of a problematic assumption, but obviously your end diastolic volume here is quite a bit higher.
If you say clinically, from a clinical point of view, how do we use that?
Sure, yeah. So translating this to a clinical situation. So what we have here is a reduced inotropy, right? So for whatever reason that is, let's assume this is a acute MI. How do we restore this curve back upwards and shift that back towards the normal pressure-volume relationship? So if this is an acute MI, obviously open the vessel. If the heart is stunned in the acute situation, what are you going to do to unload that, right? So you have a problem with inotropy and you're too far shifted this way. So we'll go over the curves for the other devices that will help us unload that throughout here. Do you have any questions about that?
Always a question in my mind: is it better to bring it back to where it's supposed to be, or is it better to leave it alone where it was, since it could be one of the nature mechanism of patient for clinical outcome?
Yeah, it's a good point. Well, let's look at some other curves and we'll see.
With entropy, which is increased chaos, means you're going to die and the whole universe is going to extinguish eventually. So you can't just follow nature.
We're going much deeper than arguments here, like philosophical nature of the universe. I'm sorry?
There's like the end systolic pressure as a surrogate for afterload, like at the tip after aortic ejection at the top of the curve there.
Sure.
Yeah, that point right there. Like on some of these pressure volume loops, they have like a curve that goes through like the afterload as far as like elastance or something like that.
Ooh, elastance, yeah. So
that's a whole other ball.
That point with afterload.
Yeah, so that's a whole other ball. Elastance, I believe,
is the inverse of compliance. Yeah, I didn't go too much into that. That's a good point. But if
I always get confused over that point, but anyway.
Yeah, EES, I think, is what you're talking about.
Yeah,
on that curve there.
They take into consideration the pressure and the radius and like all thickness and all that stuff.
Yeah, and then there's the NREP effect too. We also have, you still want to depend on
afterload for cardiac output. Yeah, I didn't go into that too much. Those are all really good points. I just kind of wanted to apply these to clinical things that we had.
Right?
Sure.
If you draw another line that intersects your end systole and your contractility, and you draw that slope, that represents your elastance.
Elastance, okay. Yeah, good, thank you. So acute LV failure, this is a bit overwhelming, so I'm not going to go too much into it. I'm just going to focus on maybe the Swan-Ganz. This is some of the more practical stuff that we're going to see here. But obviously, like I said, you can see the PA diastolic is quite high, and our PAPI looks good, so obviously this is just acute LV failure. In a quick way, it's nice because when you're doing these PAPIs, you can just say, okay, 46 minus 30, that's 16 over 9. Our PAPI is reasonable. And obviously our cardiac power is not good, and our wedge is high. We don't have a ventricle that's unloading very well. Of course, wall tension being high, increased myocardial oxygen demand. So we take this, we go from this curve here, we say their inotropy is poor, so let's add an agent to augment that. And in this case, we're going to add dobutamine. So, Dr. Gualdoni, sorry to pick on you. What changed here on the curve? What did you? All right, next slide. I'm sorry. Yeah. So what changed is that our stroke volume just went up. We shifted our pressure volume curve upwards, right? So we have increased inotropy. Obviously, we added dobutamine here. And we're seeing that the stroke volume is increased, and we shifted that curve upwards. Looks like our wedge is still pretty high, so we're still not adequately unloading, but our cardiac power is now adequate. I'm sorry.
Significance of your CVP.
What's that?
What's the significance of your CVP?
Of my CVP? Well,
Good question, thank you. So I would argue in this curve here, it's weird that I'm assuming these aren't the same patients because that doesn't quite seem right, but in this patient here, we have a high wedge pressure, obviously, but we have a low cardiac power, right? So in this patient, I would say we need to increase the cardiac power. Obviously, if you add dobutamine in, as in this patient, it seems like now, okay, we've checked off, we've had good cardiac power, and I think the CVP is more of it can be the loading conditions of the heart, but you need to first say, hey, do I have adequate oxygen delivery? And then once you've made that, once you've increased the inotropy or whatever you need to do enough to increase oxygen delivery, then we can say, okay, what are the loading conditions of the heart now that we have adequate forward flow, right? So that's why I think CVP is, assuming that CVP, that volume equals pressure, is extremely problematic because we have to first assess, do they have enough adequate DO2? Are they delivering enough blood and oxygen to the peripheral tissues? I think that's one of the primary things we should focus on first. Because if you diurese this patient, let's say their cardiac power was 0.5, I think diuresing that patient actually has the potential to do harm until you've established better forward flow. So that's a good point. Thanks, Jill, for bringing that up. But I'd say in this patient, okay, we have adequate forward flow. We've got enough cardiac power. We've got a good cardiac index here. And now we have, what we're seeing is maybe their CVP of 12 isn't too bad, but we're seeing a wedge here of 23. So this patient probably needs to be diuresed at this point, right? We've got enough forward flow, and we're just congested at this point. But yeah, so we see the pressure-volume relationship shift upwards, increased inotropy, increased stroke volume, and a little bit of reduction in that triangle size there as well that you pointed out. Of course, the heart rate's higher too because we've added an inotropic agent and a chronotropic agent as well. Okay, so we've added an afterload increasing agent. We've added norepinephrine here. Dr. Stevenson, would you like to tell me what we're seeing here?
You're seeing a dramatic increase in afterload because the end systolic pressure is higher. You're also seeing an increase in the end diastolic pressure as well. And actually the stroke volume looks like it's decreased. I don't know about and maybe the stroke work has, I don't know, it's the area under, so maybe the area is a little bit less.
Yeah.
But your end diastolic volume is higher and systolic pressure is higher.
Yeah.
And
At the higher work.
higher, right.
Exactly.
EVP is high.
LVEP is higher, right? So I'm not sure really health matters for
Yeah, perhaps
compensating heart failure.
worse. Yeah,
Yeah.
exactly. Yeah. So it's having to pump harder because it's pumping against a higher brick wall, I guess. It's a higher threshold to eject blood.
So it's like VA ECMO without unloading.
But the contractility has increased.
Exactly.
And there is,
So you're whipping on a dead horse.
yes, exactly. And this is a good point. So when we have these acute MIs that come in, the whole
Point, this is a good point to talk about why we do advanced therapies like devices is sometimes the inclination is to say, oh, we should add inotropy, but in acute MI heart, you don't want to increase that myocardial O2 demand because you can provoke arrhythmias and you can send them into VTVF, those kinds of things. So that's kind of why we don't want to tap into that myocardial reserve when they're acutely ischemic in that situation. Go ahead. Sure.
Load. So the steeper this line represents the contractility, and like I said, if you draw a tangent at the end systole intersecting the contractility slope, that represents your afterload. So steeper that line is increased afterload. So if you go back to dobutamine, you see that slope has gone down.
There is a laser point.
You draw the line from the end systolic pressure to the end diastolic pressure. Where's the second point that you're drawing the line?
Oh wow, that's
It's not on purpose.
yeah, that's quite a laser.
And systolic.
Oh, I see.
Yeah, so that represents your elastance or afterload. So as you can see, after you add dobutamine, it's becoming more flatter. So that's decreased afterload because it has peripheral vasodilatation as well. And then if you show the epinephrine, next slide.
It was norepinephrine.
So norepinephrine. You see it's more steeper. So it increases afterload because it's a vasoconstrictor.
Steeper where in the LV, the red one?
Yeah.
Oh.
Say imaginary line.
Yeah, it's not drawn here, so you imagine. So it's all Dr. Stevenson's fault of bringing up elastance.
Sorry,
It's good
I
for the
was-
nice guy.
Yeah,
Sorry
it's
about that.
for our astronomy
So,
essentially.
so Dr. Roach,
Sir.
I wanted to ask you that. So when you're standing next to the patient in the room, how do you visualize? And I want to know, how do you do that? These pressure loops are really helpful on paper here.
Yeah,
But how do you take this information to the patient?
it's a good question, and I know
It's not often that I would think of a patient as necessarily a PV loop. I think the first question for me is going to be, is there adequate tissue perfusion? That's the very first question. We've made the assessment, we think they're in shock. So what is the first thing I need to do? I need to restore adequate DO2. With ECMO, we want that 3 to 1, at least 3 to 1 DO2 to VO2 ratio. And for these patients, my first question is always going to be, do I have enough tissue perfusion? And I'll be focusing on, for instance, this number. And I think these are helpful to help digest the concepts, but as far as practical applications of PV loops at the bedside, I don't think I think that understanding these concepts and discussing them helps to make decisions,
What you're doing?
exactly.
It would make sense of your therapy, your
Yeah.
mechanical support. You'll understand why things are happening.
Yeah, I can't say I would, have a patient in front of me who's
encouraging shock, and I'm not drawing a PV loop on the board outside the room and saying,
Nobody do that these days, at least. Nobody does,
None of the monitors will do that.
No, you have to have special. There are devices you can get to plot out these loops, but no,
Yeah,
we
but
don't.
Intelligence, you can put the dosage and it will give you the loop.
Yeah, that's what we do.
Yeah, imaginary loop. Let's put the dobutamine at 5 and it will give you the loop.
Even this exact software you can use.
Yeah, I'm sure.
You don't even need the AI.
Yeah.
You can
But what
have
is the-
your patient's variables entered in this exact software. It will
On
give
the
this
hardware,
patient's
you mean?
loop.
Yeah,
It
it's
will give you
pretty
that
robust. It's
particular-
crazy. You can even just to have fun with it. You can just put like 1,000 mics of norepi just to see with the curve. Obviously, it would be an extremely narrow curve because the afterload's so high.
Error 403 not found.
Swans in most of the patients?
I'm sorry.
You guys are putting swans in most of the patients? It seems like you're helping guys.
Personally, I'm a big fan of swans, but I think the escape trial showed what it showed, right? But it's just a device; it's not an intervention.
In my mind, a lot of things have to fall into place for a swan to be helpful. It has to, I think, for me to put a swan in it, I have to feel like I'm doing a bedside echocardiogram with our ultrasound machines. I'm assessing their hemodynamics, looking at their labs, looking at everything, and I still have a question that isn't answered. Because I think a swan, it's a relatively risk-free intervention, but it has to be set up, it has to be put in correctly, it has to be set up correctly, calibrated correctly, and then you have to get good numbers, and you have to know what to do with the numbers correctly, and that in and of itself isn't an intervention. Then you have to choose the correct intervention based on the Swan-Ganz catheter. So I think there's a lot of, you have to have the right resources in place, and you have to have a question that isn't otherwise answered with less invasive stuff. When I have that kind of situation where I feel like I'm unclear, maybe it's a mixed shock, I will put that in. Or if I'm going into cardiorenal syndrome and I'm on inotropes and I'm trying to diurese, but things just aren't going the right way, that would be another situation we'll put a Swan-Ganz in and try to get more targeted therapies based on numbers.
Helps to interpret what the numbers are And then, unless there is something wrong with the way you put in and normalize things, you have to trust the numbers. I'll give you a very good example recently. I had a patient who came in recently with acute MI that was, delayed care for about 4 days. And so patient is hypotensive, so we put an Impella in, put a Swan-Ganz catheter, did the intervention, and we were finally getting our numbers, and the PSAT was very high, which is completely opposite of what you should expect, right?
Sure.
So, and this was like at 12 o'clock in the middle of the night thing. So I suspected that, the only thing that you can expect in this setting is a VSD. Yeah. And so patient got stabilized a little bit, and the treatment for VSD is an Impella and treat whatever is there, right? So we then sort of started the process of, calling other centers where they can do this stuff, and the next day, on echo, you can clearly see the VSD. So the numbers are numbers. I mean, if you have done everything right, you have to trust the numbers.
Yeah.
If you had not looked for it, we would not have diagnosed the VSD.
Absolutely. Yeah. I think
I'll take one. I agree with what you say. I'll say sometimes you can't trust the numbers. So we for instance, our Swan-Ganz catheters, and I think most of them now are thermodilution technique. I would say that thermodilution can be problematic, and I've noticed that in our ICU that we pretty much only use thermodilution. We've made decisions based on thermodilution when they have maybe severe TR, and then you check a mixed venous or something like that, and it's 65, and it's like, well, we're going up on inotropes, or in reality, their heart's adequate, their perfusion's adequate, but the thermodilution for one reason or another has been off. So I do agree. I think it's just with certain caveats, like let's make sure that we verify our thermodilution cardiac index with a FIC, in like that kind of situation. Because I've noticed that we will rely on those numbers, and a lot of the times the nurse will be like, these numbers don't make sense, but like we're just going to go on the numbers. So just at least say, when is the thermodilution going to be inaccurate, or when should we verify that is correct?
So always will check the FIC.
so. I will. I don't think it's part of a protocol yet to do that. But if I'm gonna
make decisions based on Swan-Ganz numbers, I will almost always verify that the index is correct with a FIC, and then try to rectify if there's a difference, why that is.
Statement yesterday for low hemodynamic states to use FIC, and for higher hemodynamic states you use
thermodilution. Yeah.
I personally, no, I more so, I want to verify that I'm doing that, maybe there's some complicating things like, again, TR. There's other reasons why the thermodilution will be inaccurate. There's reasons why the FIC will be inaccurate, right? You don't want the patient to go work with physical therapy and then check a FIC 5 minutes after, because their mixed venous sat will be low, and that's going to be a falsely low. It's not a true assessment of their perfusion at that point. So, yeah, does that answer? Yeah. No. This is a really dry subject. So this is really dry, so I'm glad that we're able to sort of have a conversation outside of it. But yeah, so we can see we've added norepinephrine. We've kind of made things a little bit worse. Let's just assume it's the same patient. We're really close to our threshold of an adequate cardiac power. Our filling pressures have gone up because, as you had pointed out, our afterload is so much higher. The EES is much steeper there. And you can see our Swan-Ganz filling pressures are higher as well. And it looks like our PAPI has gone down. So epi, anyone want to take a stab at what's going on here when we added epinephrine? So norepinephrine, we'll take a step back. Mostly alpha agonist, and then the norepinephrine has a slight beta agonist activity as well. But epi obviously has a different hemodynamic profile. So let's see. Ooh, Dr. Marmouche.
We have more increase in afterload now, and filling pressure is higher. Your wedge is still high with the right side of filling pressure. PA pressure is still high too.
Yeah. So again, the elastance curve much steeper here.
Or stroke volume too.
Yeah. So it did increase. Looks like our cardiac output somewhat, but it's we have very high afterload at this point, very high filling pressures, and obviously our PA diastolic is really high as well. So.
So one thing that the Frank Starling's law, right? So the relationship between volume and pressure, it is linear to an extent, but after some point it is non-linear. So even small increase in your end diastolic volume will significantly increase your end diastolic pressure. So as you can see on that x-axis, the loop becomes much more steeper, even with small increase in the volume.
That's right. Yep. Okay. So intra-aortic balloon pump. I liked this one because it showed. It doesn't seem like it's augmenting a whole heck of a lot, right? A balloon pump. So let's see here. Maybe want to take a stab at this one. Tell me what they're seeing.
I mean, the most pronounced change here is after load, slight reduction, or actually your curve hasn't changed a lot.
Yeah.
But there's slight improvement in filling pressure. Stroke volume almost remained the same. You're just moving more towards the left.
Yeah, it looks like this gap is a little smaller, but this one's cut a little bit bigger. So maybe that's helping helping unload the heart a little bit when the balloon deflates, of course. And then when it inflates, maybe we're perfusing a little bit better and getting a little bit better contractility out of it. But it doesn't look like the contractility is really even affected very much at all here. So we still have a narrow pulse pressure there. We still have high filling pressures. PA diastolic of 29 or wedge of 22, and a barely adequate cardiac power. Mixed venous O2 sat of 64.
Slight increase in stroke volume is purely from afterload reduction.
Yeah.
You're not changing your contractility. You're just merely reducing your afterload, and that's why your stroke volume has slightly gone up. That's all.
Yeah. So, and this is nice because we can start to think of like, okay, we're talking about mechanical devices. What are we really going to get for it? And we're not getting a whole lot with a balloon pump, right? It's kind of, go ahead.
If your cardiac index is okay and you just want to reduce afterload, a balloon pump could be helpful in those situations, because I know Prashad always complains about the Impella, like a $40,000 device. Well, which patients is it okay to use a balloon pump in that heat of the moment? I mean, that's always what I'm thinking. Where there's no data to say that any of these devices help improve survival. Well, can I get by with the balloon pump? Well, that would be the patient that you could get by. Maybe an inferior wall MI that's been revascularized, that just has some transient hypotension. You don't want to put a 14 French Impella in there just for it to be removed in a couple of hours. Just put a balloon pump in that patient. That's such a difficult decision though, because you go to cath conference and the patient doesn't do well, then someone's going to tag you and say, hey, why didn't you put an Impella in that patient? Well, I was trying to save money. Well, that doesn't sound right.
Well, I think if you put your swan in, right, that's the first suggestion to us. We never want to put swans in. If you put a swan in, you get all these numbers. You can stand on your feet and say, this is what I did, whatever you did.
That's true. The whole swan argument is so tough, though, when you're in the heat of the moment, because you're trying to save that crashing patient. And the academician will always say, oh, we'll do a swan, do a PA catheter and get some pressures. But wait, my patient's dying in front of me. I want to open up that vessel. I mean, that's the thought when you're there.
So, yeah.
Right.
Let's take a moment here to
I mean, that's what an intervention
summarize yesterday. If you
about.
call the ICU, we're more than happy to come down and help you.
Yeah, it's not a matter of putting in the actual catheter. It's the sequence of events.
Sure.
And I don't know how you guys feel like when you have a cardiogenic shock patient there. Do you guys always just pause, take a breath, do the right heart cath, get your data?
I think you already mentioned it's time dependent. It's how acute is the situation? Like, the patient we had to put on ECMO a couple nights ago, it was like we didn't have time to get all of our numbers, and barely had time to get a swan. We just like, we know we could do it, so we're just going to do it. So. Yeah.
Well, in the cath lab itself, you get some time by using pressors. You give some neo, you give some epi. When you buy some time with that, and then sort of, fix the acute problem if it's in a closed vessel, whatever it is, and then sort of, get that data, and then you can do the right thing.
Other utility of potentially could be the VA
right to the ventricle.
You know, those are great comments. Those are great comments. So, you know, balloon pump is definitely a valid sort of device to use, especially in an acute situation. The patient's crashing, you want to try to open up the impella, put it in, not sure about the bleeding part, about the anticoagulation, so many things that goes on in cath lab. It just makes it really hard for you to pick and choose. But overall, there's no difference in the outcomes. That's number one. So whichever is at ease, if you want to pull out a balloon pump, you want to put it in, especially a younger patient coming with an acute MI has had no compensatory mechanism in play. At that time, the easiest thing is to put a balloon pump in, use the afterload, provide a little more higher diastolic pressures, improve current perfusion. A lot of times they do well. A lot of times they do well. Even though we sort of shun away from escalating from balloon pump to impella to an ECMO and all those things, at least have a balloon pump open and do it. That's the easiest thing. And actually, it's very forgiving even for anticoagulation. We've had one-to-one balloon pump augmentation with no anticoagulation. It might be a different situation with acute MI, they all need anticoagulation. But I think it's a very forgiving device. And I have a couple of cases I'm going to show you that balloon pump works really well with a lot of these patients.
We use sometimes these numbers to our advantage just to prove our argument. You know. If you like the mortality across the board for cardiogenic shock is bad, 80% or so, 75, 8 greater than 75. So when we want to say that we did everything, the patient died, and then we say, well, because the mortality was high. And then when we put a balloon pump, we say, you know, this was a balloon pump which killed the patient, you know, because, but in reality, the protoplasm were bad to begin with. So I think these devices, they can help you get through the procedure quickly. I think how proficiently you can do that, and not to talk about such a big, 14 French or so you're putting this sheath in there and the complications ensue after that. You know, so I think, like you pointed out, and I fully agree with John that I think it depends on the patient, the timing, how much time will take, and what will get you through the procedure. And the really story starts when the patient, the shock hits the patient after acute MI in 24 hours. You know, that's when all the lactates and all these things, they bring the blood pressure down, and then you're wondering all these questions. Should I put a Swan-Ganz? And you're always kicking yourself, maybe I should have. And so I think that's what he's talking about, the after the fact when people start discussing the cases and so on.
Yeah, I mean, first put in something to help the patient.
Yeah,
and that's what it is.
I can chime in here, you know.
Swan-Ganz and all those assessments.
But I can chime in here. I mean, I recently had, like, you know, this collaborative kind of effort, since we're talking about, I was recently doing a case at Chandler. It was a, you know, tough LAD stenosis with calcium and all that kind of stuff. So we did proto, shockwave, all that kind of stuff. And it turns out patient did not get adequate anticoagulation. I mean, that's a system issue, you know, that we kind of dealt with later on. But I'm putting my final stent in, suddenly, you know, there is thrombus in the left main, the RAMA shut down, there was slow flow in the LAD, and, you know, we gave some pressors to get the blood pressure up, but then the patient had VT, and so we had to shock him. So once you have VT, you know that the LV is going to be dilated. So a balloon pump is not going to work, and plus I need time to go in and fish out the thrombus, do all that kind of stuff. So I took my guide out, I took my wires out. I put an impella in, I went back in with the 7 French guide. So once I put the impella in, he settled down, then I was able to get my guide back in, did thrombectomy, stenting, whatever is needed. And then we called the ICU to intubate the patient because, you know, we don't want to have respiratory issues. You know, I'm not sure if it was you or one of your partners who came down, and actually I was shocked to see that person stayed through the end of intervention, and, you know, was adjusting the vent and stuff. And in the end, I put a Swan in, moved the patient to the unit. Obviously, he had some damage to his heart because that brain was closed down, the LAD had slow flow. But over 2 days, he recovered. You know, he went home, and I saw him last week. This just happened literally a month ago. So it was a great collaborative effort in the sense that whatever triggered the problem, you know, how we take care of that stuff, and, you know, amazing collaboration by you guys, you know, it really helped out. And so, you know, my experience has been, you know, whenever I call someone for intubation, they come and intubate and leave. But, you know, now I'm sort of taking care of the respiratory aspect of it. But the fact that one of you guys stayed and sort of took care of that aspect, it made me work faster. take care of the patient. So
And that's good to hear. That's what I really hope from our shock team, or forthcoming shock team is we had a couple of cases down there that ultimately went on ECMO. One of them got a heart and kidney at Mayo. It's funny she mentioned that they do that there. And the other one got decannulated from a 5.5 and is out walking. We got involved in you guys were revascularizing and doing everything, but we got called down to do an airway. And then I kind of was like looking, well, we're on like 2 pressors here, and the Impel is in. And how are we going to land the airplane? And so, but no fault to the interventionalists. I mean, they were trying to get the vessels open. They were trying their best to save the patient, obviously. But they're not necessarily thinking like, what's my dose of norepinephrine when they're trying to, angio and angioplasty, all the coronaries, what have you. So we were kind of asking those questions like, hey, what's the next step? What is our plan here? Run 2 pressors. Like, should we escalate the care? Hey, let's put a swan in real quick and see what the RV is doing. Like, what's the appropriate device? I think because of that collaborative effort, we had 2 really successful cases that weaned from VA ECMO to just total explant, and one of them was heart and kidney. And I think the collaboration there was really a big part of those good outcomes. So, but both of those we were called down just to kind of look at the airway, and I was just sort of like, hey, this doesn't seem like it's going too well with what we're doing now. What's our next step? So I think, thank you for bringing that up, and that makes me really happy. I think all of our ECMO and shock team are really, really wanting to just be helpful in those situations and help you guys get those outcomes.
Is it fairly safe to say this or assume this, that when we call you guys, and we may even ask you to do a swan from the IJ while we keep working doing Impella or trying to focus on the coronary, is that a reasonable request to not only just help with respiratory and drips and stuff, but also go ahead and start doing a swan while we take care of what we need to do from the
I did that 2 nights ago. Yeah.
If you have a groin access, putting a swan by the interventionist, that
yeah, but sometimes like in acute situation,
you'll be hitting in the eye.
Let's.
Okay.
Yeah. No, to answer your question, 2 nights ago, and we'll continue, but 2 nights ago we had somebody crash and burn unit in the cath lab. The fellow was in. They're on 30th norepi, starting epi and all this stuff, and they're trying to revascularize. And I said, hey, let me get this one in. Let me define our hemodynamics and see what the right ventricle is doing. And so I was doing that while he was trying to, revascularize, and it worked quite nicely because everything kind of fell in place. Sir.
All of us put swans in.
Right, that's why I was.
That.
Yeah.
So that's going to be more of a who's on and who's available situation. But as far as the collaborative discussion, it's kind of what I mentioned yesterday, how in a code situation, somebody's doing the technically difficult stuff with the airway. In this situation, somebody's doing the technically difficult stuff with the heart. Have a different person be able to target their focus in the hemodynamics to facilitate the situation. Just like surgeons have anesthesiologists managing stuff, it really takes 2 in these patients that are that critical.
Thanks for bringing that up, Dan. That's a great point. So, yes, maybe some people are not comfortable putting swans in, but if you've got that sick patient, you need somebody to manage the acidosis. You need somebody to help manage the drugs. For instance, not only do we put in the swan, but it's like, hey, you guys are on 60 of propofol. That's going to bring your end-systolic pressure volume relationship down, and you're going to reduce inotropy. That's a negative inotropic agent. So we're thinking of these things. How can we optimize? How can we optimize their ventilator settings? How can we optimize the acidemia? How can we optimize forward flow and reduce the myocardial oxygen consumption in a critical moment like that? So I think that's a lot of stuff we can bring to the table in addition to just the Swan-Ganz and an airway. Oh, I'm sorry. Okay. Well, why don't you tell me what we're seeing here then?
It doesn't look like it. There we go. Here. All right. So I see that there is an increase in the end diastolic volume. Okay. There is an increase in the end systolic pressure, but the stroke volume is lower and the contractility is more. And if you do the afterload is increasing the afterload too.
Can you put that together? Can you tell me why we're seeing that?
Because we're adding more volume to the patient. We're pulling, from the right side, and then we're putting it up in face of a failing heart. although
Yeah.
we're increasing the perfusion and the cardiac output, but we're putting more volume in front of a failing heart.
Exactly, yeah. So we're shooting blood towards the aortic valve and opposing the flow from the left ventricle. So that obviously is going to increase afterload drastically. And so we've made an incredibly sharp elastance curve there. And now it's really hard to eject blood from the ventricle. Go ahead.
Point, or what does the curve look like when you decide that you need to vent the heart?
So,
Good segue.
quick comment about this slide is that we have to interpret this in a different way, because when you are on ECMO, you are literally on a bypass, right? So you are not looking at your left ventricle performance here anymore. The take home from this slide is that you are increasing your MAP at the expense of increasing afterload. You don't really want to look at the stroke volume and stuff like that, because that's the whole point of the ECMO, is to rest the heart.
Yes.
The volume that's being
ECMO
injected by the
plus
ECMO
what's
plus the heart.
injected, yeah. So the true, I would say one thing though, fortunately this patient is pulsatile, right? There is some blood coming out of the left ventricle, so the left ventricle is being unloaded, fortunately. But if you do not see this pulsatility, and I want to point out, like, we have a difference in their systolic and diastolic. You have curves here. We have pulsatility, the PA waveform, so the right ventricle is moving as well. It's ejecting blood to the left side. But I will say that if this is not happening, if you have just a flat A line and you're totally dependent on VA ECMO, you're going to keep sliding up this way. And you're going to go into pulmonary edema, stagnant blood. You can get clots in here as well.
Yeah. But that makes sense. Why wait to that point? Because eventually you know that the heart is going to distend.
Yes.
And it's going to fail and lose pulsatility.
Yeah.
So, and then keep going. In my mind, things should go hand in hand. And Ram probably can comment more that when you put the VA ECMO, you need to vent the heart,
I
no
think
matter
that's,
what, immediately.
Yeah, it's at high volume VA ECMO centers. It's almost ubiquitous that you have ECPella is the terminology for it.
Contractility at all, right? Because the
No.
contractility,
No.
right?
Yeah, and that's
That's the problem. All that's a problem.
Both the ventricles are underfilled at this time.
Right.
So predominantly, it's in the peripheral circulation, going back and forth. So it also depends on how long you're going to keep him on like this. So if you keep him more than 3 or 4 days, you're going to start noticing the left atrial pressure going up. You start doing a chest X-ray every day. You start seeing fluffy lungs on left side and right side. Despite diuresis on CRRT by this time, when he's on VA ECMO, despite that, you know, at that point, you don't want to wait. You're right.
But my point, why wait to that point?
Correct. So, it is definitely an added procedure. There's no question about it. So, a lot of times what we do is not only for unloading the LV, when you start coming off the VA ECMO for a person who's got a EF of 10% or 15%, very dilated ventricle, so you have at least the ECMO support when you completely wean off the VA. Eventually, you want to wean off the patient off the VA ECMO, and then keep him on Impella support or some sort of afterload support, unless the patient is hypertensive. A lot of times we've seen this within 24 to 48 hours. The blood pressure is 120 over 80, 130 over 80. At that time, it's a great time for you to start coming down the flows of the VA ECMO and start weaning off the VA. But if the guy is going to sit like this, what you're saying, there's no pulsatility in the arterial waveform, you know the heart is not going to come back around. That's a great time for you within 24, 48 hours, act on it, put on a VA Impella. And a lot of the times when the patients are sent for a VA ECMO, they already have an Impella.
Also, Ram, like what pulse pressure do you use to make that decision of,
There's no cutoff. It depends on what the underlying pathology is for you. Acute MI who comes in, probably will be a little more pulsatile than a person who's got chronic heart failure, very low pulsatility index. At those points, we really can't. So it's going to be depending on the patient.
That's really good. So 20% is what you want to wean ECMO. Just you see about a 20% pulse pressure variation above the diastolic pressure there. You want to see about a 20% increase in your systolic over that. That's very, very rough, and it's very clinically, if you have an acute MI, so sometimes you can maybe add inotropes, which is probably not the right strategy in acute MI. When you're on VA ECMO, you want to try to avoid that as much as possible, but you can add inotropes, you can reduce ECMO flow. All those things will try to induce the pulsatility and left ventricular ejection from the aortic valve. I'm sorry, you had a...
Yeah, so is it fair to say that in these cardiogenic shock patients, VA ECMO is more relevant if you have oxygenation issue 1 to RV failure?
sure I understand.
So oxygenation issues, like, you're on the vent, patient's not oxygenated.
When you're doing your escalation, VA ECMO.
And two, if you have significant RV failure, that's when VA ECMO will change the issue, will change the hemodynamics. Because, at this point, if the impella fails, that means your lungs are flooded and you cannot oxygenate this patient, or you have significant RV failure too, and therefore the impella is not helping.
Yeah, well, certainly, I'm not sure I totally understand the question, but
Like when we do the indication, yeah. When you have bad RV failure and oxygenation issue, that's the only indication for
okay, I see what you're saying. So, and that's kind of part of the process, right? So we'll put in the Swan-Ganz catheter. Again, it depends on the clinical situation and the acuity, right? So if they're hot and heavy, crashing and burning, they come with a massive MI, it might be just appropriate to put whatever in you can get as soon as possible, right? Just throw something in and get them supported. The guy we had a couple nights ago, he was total crash and burn as well. He started coding as soon as we were, getting everything set up and trying to make decisions. We're like, well, we'll just crash him onto ECMO and then go from there. But if you have the time, put it in the SWAN and say, okay, let's define the hemodynamics. What's my PAPI? What's my CPO? What is the actual problem here? And then you can make decisions as to what the appropriate support device is. So it's just totally situation dependent. Oxygenation, obviously you're not going to want to do something without an oxygenator if they're profoundly hypoxemic, but oftentimes you can manage fine with the ventilator. And if they're in pulmonary edema, maybe they're just not unloading their left side, so maybe just increased left-sided support is more appropriate, like the Protec, or not the Protec, I always forget these, the tandem heart, the one without the oxygen, the transeptal, the transeptal pump there, without an oxygenator. So it's just very situation dependent, and I think it's acuity dependent, and once we can start getting numbers, if we have the opportunity to do so, we have more time to say, hey, what do you think about increasing RV support? We've got a PAPI of 0.5. Maybe a Protec in that situation is but as far as the oxygenation portion to your question, again, it's hard to say, because if they're intubated, maybe we can get away with just giving them higher levels of mean airway pressure and pushing that pulmonary edema out, and that's going to be sufficient. But if they've aspirated, certainly something with an oxygenator might be a better choice to reduce lung injury from the ventilator itself. So.
Changing the contractility with ECMO. The purpose of ECMO is pretty much to rest the heart while things get better or the other way. And to Dr. Nasir's point, why not just put Impella in everyone up front, like the case that you're going to present? I think that case actually represents that depending on the etiology and acuity and the expected recovery, why you may not need an Impella in all the cases with ECMO.
Sure, yeah. And thank you for pointing that out. So VV ECMO, the point is to not further injure the lungs with the ventilator. The point of VA in an acute MI setting, at least, is to allow the heart to rest and not further injure or increase myocardial oxygen demand on a freshly ischemic heart with, say, beating up with inotropes and then worsening end organ perfusion with vasopressors and all that. So it's kind of that's the proper way to classify VA ECMO or think of VA ECMO in these situations. So now we're going to add an Impella to the situation here. And would somebody like to tell me what the difference is between this loop here and this loop here? An interesting kind of triangle now instead of a loop there. So we go back here and then here. Which changed?
Lower now.
Yes.
And the workload is lower.
Yes. Yes. The less work for the heart, right?
Yeah.
We are having theoretically less left ventricular myocardial wall
But
tension.
they both are abnormal loops now.
Yes, that is good.
And then there is no systolic volume of the LV. It's all being pumped. It's pump dependent.
We're totally resting the heart completely. We're allowing it to unload, and we're resting the heart almost completely. There's no pulsatility here anymore. The heart is just completely, well, I guess the right side is still delivering to the left, but the left side is just letting the pumps basically do most of the work. And that's an ideal situation because you're not increasing myocardial oxygen demand on the left ventricle, assuming this is an acute MI. Let me go back here. So, and we can see here our wedge of 34, right? And we put in the Impella for ECPEL, and we're wedged down to 26, right? So we have an adequate cardiac power, and we have a pulmonary capillary wedge pressure that is significantly reduced.
Impella is always gonna look triangular because the valve is immaterial, right? You have a pump continues flowing across the aortic valve. That's why it's a triangular. You don't have that aortic valve open and aortic valve close phase, right? That's which is the top line. You know, you don't have that.
If you have pulsatility,
Yeah.
the aortic
Yeah.
valve is still open.
It's a good point. So we have, good point. We have no pulsatility here, so there's no opening or closing.
When you put the Impella, what's your endpoint in a sense, using the Impella? I mean, always you're gonna go to P8 immediately, or you're titrating just a little bit of venting, and
So-
looking at the aortic valve opening, and you keep it at P3, P4? How do you titrate this Impella settings?
So a secondary benefit of having an Impella is you can actually wean VA ECMO to Impella. That's not always. Sometimes you need 5.5 to step down, but sometimes if the left ventricle really improves quickly, you can just take them off ECMO and the Impella may be enough to bridge them the rest of the way off. So when we put somebody on VA ECMO, we immediately drop down to like P2. Just leave it at P2, P3. And that's usually sufficient to unload. Now, if you want to get more pulsatility, you can turn down ECMO flow and start messing around with Impella. If you want to wean to Impella, you can start going up on Impella support and wean your ECMO support to see if you can bridge, if it looks safe enough to bridge them to just Impella without ECMO and explant.
Or are there cases where you start with the opposite? Is there any instance where you do the opposite? I mean, I'm just kind of trying to understand the weaning situation. You always wean the ECMO first and get rid of the big devices, and then the Impella you can wean over a period of time.
Yeah, I mean, because ECMO has so much complication, right? Bleeding and, all kinds. It's such a, high intensity, high acuity therapy and with a lot of risk. So we like to wean them off the ECMO first. Wean them to what? That's always going to be dependent on the clinical situation. Sometimes an Impella 5.5, sometimes, the Impella CP is enough. Sometimes you can just explant. It's just hard to say. You just have to, it's a kind of a bedside sport where you're always there just kind of trying to ramp them down and see what they do when you wean the flows and see how their heart tolerates it. Oftentimes when you're starting to wean the flows and your pulsatility goes way up, their left ventricle appears as if they're doing a lot better. So it's just, go ahead.
ECMO as well as Impella device. Do you have antegrade sheath in both the femoral, and where do you give the collateral from both the radials?
The collateral.
For the lymph perfusion.
Oh yeah, distal lymph perfusion catheter.
Yeah.
Okay. Yeah. So it definitely gets a little tricky because you got a lot of sheaths in, so we have to get a little creative sometimes. But ultimately, at the end of the day, if you need to, you have IJ access. You can theoretically put a catheter through there to get your drainage cannula, but you're usually only using one of them for your access site, right? For arterial. So typically next to that arterial is where we use the venous. Ideally, we'd like the right side for arterial cannula access, but it doesn't make a huge difference. So if you're using the right side, we'll use that venous right next to it. We'll put the venous cannula right next to that. And then if you're using then we'll use the other side for the venous. Well, so yeah, that one's taken, site's taken. So the venous will go right next to that.
Perfusion. So
And
if
then
you're gonna integrate sheath, so if you have a arterial cannula for ECMO in the left groin, you put the distal perfusion in the left SFA for antegrade perfusion, right? His question is, if you have an Impella sheath in the right femoral artery, what about the perfusion of the right leg? Do we need to put a? You might have to.
It's not.
With Impella, it's not. What do you think?
Impella is like less than 10%.
If you have to, you can put antegrade sheath and both of them.
But the sheets for the ECMO are much bigger.
Yes.
They're 14 frames.
17.
Yeah.
20.
Yeah, sometimes what happens, just the venous cannula itself is so big, like you said, it compresses the arterial side. Then you have an arterial line in. So invariably, you're going to have some sort of a drain catheter going, perfusing the distally. You just have to be careful because it's just a matter of time. It's just going to get turned blue.
I would say err on the side if we're doing ECMO, err on the side of just always putting in a distal lymph perfusion catheter. Yeah.
So that's what, 17 French.
You can.
Which is almost like a 6 millimeter.
So sometimes when we crash people on, we just do a 15 French return cannula. You don't always, in larger adult males, it's not really always necessary to do a distal limb perfusion catheter in a 15 French, but if you're using 17 and above, you should almost always do it. 15 sometimes is adequate.
Through the Impella sheath, you can put a 7 French long sheath, like we do the single axis, and then you have to figure out how you can get two male to male and connect them to the two perfusion. Instead of sticking to the third, use your perfusion, use a 7 French long sheath, and then you can draw blood from the aorta and then perfuse the limbs antegrade instead of sticking them.
Okay, that's good to know. I didn't know that.
Most of the ECMO experts recommend to not do that for a variety of reasons. First of all, the gradient is much higher with the Impella cannula has a side port, and if you and that's a big 17 French cannula, and you have a 6 French distal antegrade perfusion sheath, so the gradient is much better rather than having a opposite limb connected to the 7 French or 6 French sheath, So you just have a better gradient and better perfusion if you connect the arterial cannula to the 6 French sheath on the same side.
Of the Impella?
No, of the arterial cannula.
Of the arterial cannula.
Yeah.
If you can help it too, you should really try to put some sort of access into the SFA for reperfusion before you get the arterial cannula in. It's exceedingly difficult without fluoro to get a SFA limb perfusion catheter in with that arterial cannula there. It's really tough. Dan?
A little bit about if the distal perfusion catheters are needed, and that can be a little debatable, but the other thing to take into account is these patients are already so critically ill that if we wait until we start seeing limb ischemia, often just a little bit of limb ischemia can be enough to tip the balance to make salvaging the patient almost impossible. So rather than waiting for a pretty high likelihood of these patients, once you get above the 15 French, it's pretty high likelihood that they will develop a component of it. And oftentimes our picture is so tenuous that that's enough to tip us over the edge.
Because you get tremendous acidosis from limb
Yeah,
ischemia.
so we're already battling enough
Exactly,
things,
yeah.
and then you throw that on top of it, and it's really, really difficult.
I think it should be pretty routine just to.
How many ECMO has you done like in our institution last year? Over 1 year?
So total, we have our 13th on right now, and this will be our 6th VA ECMO case. Okay, let's see what else we got
Good for
here.
a baby program.
Yeah,
We just
we're actually
started
beating
out.
St. Joe's with cases right now.
We're having better outcomes than they are. But our goal was to get an average of about 1 a month, and so we're actually right on target, even though it doesn't sound like very big numbers.
Yeah.
No, it is high number. If you look at the national statistical percent for how often you use ECMO, 0.14 of patients that require support. That's national how it's used.
Well, some people
To
don't
me, it
realize,
seems like way higher than the national.
some people don't realize how busy our ICU is. Even though we're not the biggest hospital, we had the most throughput of any hospital in Arizona. We get patients from other states. Like I remember one night during COVID getting patients calling from Georgia. They're like, "Hey, we've got 2. Can we send them both to you?" And I was like, "We're going to bunk bed them in the airplane." So we do see a lot, and we see a lot of sick people.
I hate to say, I'm super proud. We have a brand new program, and we're doing great. We have a great team. Our ECMO team is awesome. All of our nursing staff is awesome. I work with amazing people, and I think it's humbling to work alongside such great people. So 20% of the 5 mortality rate. Yeah. So we have one on right now. Unfortunately, for some, what's that? Yeah. So the guy we had, we got him on. We're getting a little tangent, but we got him on, and he did great. Came off all pressors. He was on like 70 of levo, 30 of epi. And when I was suturing in the cannulas, he started wiggling around, like purposely trying to like withdraw and everything like that. So we're very excited about, hey, neurologically he looks great. His kidney numbers went up a little bit, and his liver numbers went up slightly, but then they came right back down, making great urine. And for some reason, he is fixed and dilated this morning. So his pupils are. So, and he has the CT scan, no bleeding, no nothing like that. There was no differential hypoxia. His PO2 and his right radial was always really good. So it seems like this one won't be a win, but it's one of those things. VA ECMO's kind of like high risk poker, right? So you win big ones and lose big ones too. Or high stakes poker. So here's Impella 5.5, and I think kind of the main, here's a CP here, just Impella CP. You can see reducing our end-diastolic volume a bit. Of course, there's a little bit wider of a triangle at the top there, I guess if you call it a triangle. You have a slight bit of pulsatility, so the aortic valve is kind of widening that a bit there. Impella 5.5, significant reduction in filling pressures there. You're really unloading the left ventricle really well. Your end-diastolic volume is coming way down. Zero pulsatility, so that triangle at the top is very acute. And your PA diastolic is 24, wedge is 15, so good solid unloading there, it looks like.
And if you don't have any oxygenation needs, like Dr. Marmoush was asking, you know, this itself might be enough. You may not need to do an ECMO if you have a patient in cardiogenic shock without any RV failure and without any oxygenation problem. Yeah. All they might need is an Impella CP or a 5.5. You're unloading, you're supporting the heart rate.
So to Dr. Marmoush's point, so how do we make decisions based on, you know, like this situation? Well, okay, I've got my cardiac power of 1. I'm happy about that. I've got a PAPI of 20 minus 11. 20 minus 11 is, so 20 over 11 is going to be almost 2. I'm happy with that too. So I think my right ventricle and my left ventricle are adequately performing right now. So I don't feel the need to escalate. And then, so do I need to decongest them somehow with diuretics or what have you? The answer is probably no. It looks good there, although, you know, CVP looks fine too. So that's kind of how we would break it down and say, hey, is this enough? And we'll go to the Impella CP here. Is this enough? Well, my PAPI looks reasonable here too. My cardiac power is okay. Maybe they need to be decongested a little bit with a slightly high wedge there, but that's kind of the process by which we'd say, you know, what's our PAPI, what's our CPO, which device is going to be appropriate in this clinical context. Oxygenator tends to be less of a consideration, to be honest with you, because they're usually ventilated patients anyways.
At that point, rather than going up to the 5.5.
I'm sorry, which patient?
I guess the patient that you showed that was on an Impella CP that had the low cardiac power and the wedge was a little high. Could you at that point put that patient on a pressor like Doppytrex instead of upping to a 5.5 and see how the patient would do?
That's certainly, clinically, yeah, in the clinical context, it depends. I usually list doses of meds here, but I don't think it does on this one. If you're on a ton of norepi and, you know, maybe epi, yeah, so it's going to be clinically so variable. You kind of have to make that on the fly with the data point for that particular patient. In case of acute MI, is this a chronic systolic heart failure that slid, you know, back? So it's so new, it's fraught with nuance, which again, I'd like to emphasize, this is why, like, having these discussions down there with you of that particular patient, you know, while you're trying to fix the vessels and save the patient, these discussions are really important because they're so nuanced, right? Which device is appropriate? Is a device appropriate? You know, what's the best way forward? And then I think this is just a normal looking monitor here. So this is what we like to see right here. Wedge is good. SCVO2. Okay, so obviously we don't need to belabor this too much. They're a little tachycardic. Looks like they're we have a wedge that's a little bit high here. We don't have an index. Looks like their SVO2 is 62%, so it's probably adequate. They're a little tachycardic, but they're narrow pulse pressure. So it looks like this patient may need probably LV unloading somehow. That's it. Sorry, hopefully it wasn't too dry. Didn't want to put everybody to sleep. So, okay. Yeah, but we can all discuss it together.
The panel, and if you guys can answer, I have a question. When you don't have a pulsatility of the pressure, how is the coronary perfusion maintained? I think the coronary perfusion is required to have a pulsatility so that during diastolic there is most of the perfusion.
Are you talking about an ECMO patient?
Yeah.
Well, it should be, they're totally dependent on ECMO flow, so the ECMO is providing all. It should get all the way back there because there's nothing you
So you're getting it both systole and diastole.
No, you're not getting any.
Well, you know,
because
if there is no contractility, right? If there's no contractility, there is no systole or diastole. So you're getting perfusion
getting
through
perfusion
through
You're getting
ventricle,
antegrade.
systole, and diastole.
Or retrograde
See,
perfusion.
the reason you get coronary perfusion diastole is because in systole the coronaries are squeezed, right? So when you have no pulsatile at all, the heart is resting. There should be flow in both systole and diastole. Whatever systole and diastole is.
No, but if the pressure inside the coronary is also the same, there is no perfusion anymore. It's stabilized.
So Dr. Kalia is that, listen, go ahead. So when you have an LVAD, there's no pulse.
Right.
So all you need is a pressure. So if you have a systolic pressure of 90 and a diastolic pressure of 25, you're not going to have coronary perfusion that good. But if you have a MAP, which is closer to 60, that's why you want to maintain a MAP of 60, 65, 70. As long as you have the diastolic pressure maintain that level, it doesn't matter whether you're going to have pulsatility or not, the coronaries will be perfused. And the RV is perfused both in systole and diastole. LV is the one that's going to be perfused in diastole. So that's the nice thing about RV and LV. That's the difference between the two. But you don't need to have a true pulsatility for you to have adequate coronary perfusion as long as you maintain a mean coronary, mean arterial pressure.
MAP minus LV EDP, right? So EDP is lower than whatever that mean pressure is. You're getting perfusion to the muscle.
Yeah, so the microcirculation really flow, not dictated by the coronary arteries or anything like that. Well, what you need the mean pressure, but all the flow in the coronary dictated by the microcirculation.
Right.
The microcirculation dilates, and you get the flow as long as you have above 60 to 80 you need in the heart. In general, you need 80 the systolic I'm talking about. But the mean, like what he's saying, if it's 60, is enough because the microcirculation is the one regulating the blood flow. And in those cases, when they need more flow, it's just vasodilate more.
And the pressure head which is pushing the blood down.
No, the pressure doesn't. Yeah, the pressure is important for many reasons when you look at the, you know, the circulation itself, all from the epicardial to the microcirculation, and the diastolic pressure play a role, right? Because it's like external resistance pushing on the microcirculation. So you need the pressure for sure, but the 60 is enough pressure. But the mean flow comes to the heart because of the microcirculation regulation.
Resistance more than
resistance. The microcirculation regulates all the flow. And the epicardial artery is just a conduit there. But you definitely, that will decrease if you decrease the pressure so much to the point it's probably difficult to get the flow that needed, but always will be flow.
I mean, such an important point because we never talk about peripheral vascular resistance. Everything we look at here is more output, more cardiac output, you know, PAPIs, RV function, echo, etc. I mean, that's the majority of the circulation is peripheral vasodilation. It's amazing. I mean,
if you think about it, when we measure coronary circulation, it is a diastolic circulation.
that's right.
Two-thirds
It is not
diastolic.
That's right.
circulation.
It's amazing. I mean, all the things that we
It's both 1/3 systolic and 2/3 diastolic. In the right ventricle side, a little bit different. They get in almost close. But in the left ventricle, in general, 1/3 of the flow happened during systole and the 2/3 during diastole. And all regulated by mainly by the microcirculation.
The reason is the microcirculation.
The contractility of the heart play a role. The contractility of the heart play a role.
Or we can say that during when we rest the heart in the parallel circuit like this, the heart is always in diastole.
Right. Yeah. That's the point.
Yeah.
The flow.
there's one pressure.
There's a pressure head which is pushing the
That's
blood
why
down.
those are not the ideal devices.
Yeah,
It's
exactly.
devices, but not the ideal
I mean, it's not
devices by
natural.
any means.
It's
They're
not natural.
friendly
Plus
physiology
the
to
lower
all.
circulation is much higher than the upper circulation, as some of these cases were described.
I think we should take a little break, but
Not
before
not
that, I really want to say, just looking at all the science and what we have been involved, I think this is a tremendous and very beneficial meeting. And the reason why, because here is the team that is going to figure out those complex cases and the tremendous also role for the hospitalists, you know, to intensive care people to join that team and try to make a decision, knowing in fact that what we have today is not a clinically evidence-based medicine. But having this meeting and this team is going to allow incorporating ourselves on the national and international level. And we have 2 trials coming, the American Heart Association Registry to investigate those devices farther and farther, and the Recover 4 trial, we're trying to see the clinical evidence. As you see, we have been talking all the time on when do we use that and how beneficial is it for patient? Is it all about just hemodynamic, bring the cardiac output from this to this or the pressure from this to this? So that is needing, it's really, we should, thank George and Dr. Shakur and congratulations. This is such an important step, and I see the nurses here, which is really critical part of that team. So this is a tremendous meeting. If I have to leave a little bit earlier, I definitely want to say this is so essential and a first step to be part of advancing and